Good morning, everybody.
We'll start with agency updates and unfinished business. Dr. Massinu.
Good morning.
Sorry.
Thank you. Happy to be here with you today. I have 3 updates. The first is an update on measles. Since January 1st, 2019 to February 21st, there have been 159 confirmed cases of measles reported from 10 states, with 6 ongoing outbreaks: Clark County, Washington; Rockland, New York City; Harris County, Texas; Monroe County; Champaign, Illinois. These outbreaks are generally linked to travelers, either U.S. travelers, unvaccinated U.S. travelers going overseas, exposed to measles and bringing it back, or travelers from outside the U.S. coming in, exposing families and communities to measles. And the large outbreaks that we're seeing are definitely in populations that are what we consider close-knit. These are people that are of similar ethnic or religious persuasion who are clustering together and are by and large unvaccinated. Obviously, the burden to respond is primarily on the local and state health department. In each of these outbreaks, as you know, there are thousands of contacts to trace in order to bring these things to close quickly. CDC is providing technical expertise. We have folks already embedded in the state. We've had folks with boots on the ground, and we also have our communication team working with the state to support their efforts. For comparison, in 2017, there were 17 outbreaks. 3 of those outbreaks were in New York State, New York City, and New Jersey, primarily associated with a large outbreak in Israel, where a really, really large outbreak is occurring. And yesterday, I did testify before the House Energy and Commerce Committee on the threat of measles, as well as the threat on people who are unvaccinated. And it was very supportive. I testified with Tony Fauci, and really 201, everybody on the committee was very supportive of our efforts to make sure that folks know that the threat of measles is ongoing and that there are safe and effective vaccines. On a completely different note, our notice of funding opportunities for the new 2019 to 2023 immunization and Vaccine for Children Cooperative Agreement was released on February 5th. This is our primary funding opportunity for eligible state, local, and territorial immunization programs, and supports a wide range of programs, including VFC, adult and adolescent immunization initiatives, perinatal Hep B, vaccine access, communication and education, coverage assessments, registries, and pandemic preparedness. To begin, planning representatives from 64 currently funded immunization programs were here in January for a kickoff meeting. The 64 currently funded immunization programs represent all 50 states, District of Columbia, 5 cities, 5 territories, and 3 freely associated state entities. Finally, an article that I want to highlight that I understand wasn't talked about yesterday. Last week, the Journal of Pediatrics published an article on the association of provider recommendations in HPV vaccine initiation among male adolescents aged 13 to 17. And this is really the first assessment that we know of state-specific HPV vaccination among male adolescents by provider recommendations. A few findings: the HPV vaccination coverage among males significantly increased, unsurprisingly, but the prevalence of provider recommendations also increased from 14% in 2011 to 65.5% in 2016, which I think is a great sign of success. But there is a real difference in provider recommendations by state, and we can definitely do better, especially in some of the states where parents report that provider recommendations aren't so strong. We know the primary driver of vaccination in any age group, but especially in HPV, is the strength of provider recommendations. So we'll be looking at how we can focus our education and communication activities to focus on those states where there's still room to grow. Thank you.
Thank you. Now we're going to move on to pneumococcal vaccines.
No.
Oh, sorry. I'm sorry, agency updates. Let's start with NBPO.
Good morning. I'm Tammy Beckham. I'm the Acting Director of the National Vaccine Program Office and the Director of the Office of HIV, AIDS, and Infectious Disease Policy. And thank you for allowing me to provide an update this morning. In 2018, the National Vaccine Advisory Committee released a report on strengthening the effectiveness of national, state, and local efforts to improve HPV vaccination coverage in the United States. Since this release, MVPO has been working to address several of the recommendations from this report. MVPO, in coordination with offices within the Office of the Assistant Secretary for Health and other agencies at HHS, like CDC, have established a three-pronged strategy for increasing HPV vaccination rates. The strategy focuses on engagement and communications, integrated delivery networks and health systems, and determining rural and faith-based needs. As part of our engagement and communication efforts, HHS will kick off the communication activities on Monday, March 4th, which is International HPV Awareness Day. These activities are designed to engage a broad range of partners to raise awareness and share evidence-based practices for increasing HPV vaccination rates. The kickoff will include a release of an HHS statement on HPV, an HHS.gov blog from Admiral Brett Dwyer, the Assistant Secretary for Health, and a Twitter chat with the Surgeon General and other partners. And you can join us to raise awareness by using the hashtag #EndHPVCancers on social media, or by joining our Twitter chat and sharing resources from our HPV toolkit, which is available at www.vaccines.gov/HPV toolkit. So promotional efforts for this will continue through April, and then we will also be working with the CDC to engage integrated delivery network systems in a learning collaborative for sharing best practices. Around adult immunization, in addition to HPV activities, we have been collaborating with a number of partners to improve adult immunization rates. Guided by the National Adult Immunization Plan, MVPO is working closely with HHS regional offices to coordinate stakeholder meetings across the country. These meetings will focus on pressing regional immunization topics such as access, hepatitis A, and HPV vaccination. And this year, we are planning meetings in regions 1, 2, 4, and 10. For adult immunization, MVPO is also co-sponsoring the National Adult and Influenza Immunization Summit with CDC and the Immunization Action Coalition. The summit will be held here May 14th through the 16th, 2019. As far as the National Vaccine Plan, many of you know the current National Vaccine Plan will expire in 2020. So over the next year, MVPO will be working with CDC, NIH, and FDA and other stakeholders to update this plan. The expectations around this is that it will involve a shorter time frame than the previous plan, which was 10 years. We're anticipating a 3 to 5 year plan, as this will allow us to be more flexible, and when new challenges or technologies emerge, allow us to address those. In addition, the plan will include metrics for success and implementation strategies for meeting the goals. So during the next year, we will be holding listening sessions to gain feedback from our stakeholders that will be used to inform the development of the plan. And finally, I'd like to share a brief update on the National Vaccine Advisory Committee. The next public INVAC meeting will be via a webcast on March 25th, 2019, and the meeting will focus on access, and an agenda will be available in the coming weeks. Thank you.
Good morning, John Beigel from the NIH. As usual, I just want to highlight a few either clinical trials or funding opportunities that might be of interest to this committee. So the NIH continues to take a focus an intense interest in influenza, specifically H7N9. There have been one study that was completed in November, 2 additional studies started since the last ACIP meeting, with and without adjuvant, but trying to make sure that we stay ahead of the need for an H7N9 vaccine. We've also started a phase 1 study for tuberculosis vaccine. It is not a tuberculosis vaccine is going to be critical for controlling tuberculosis. This is a thermostable vaccine and holds a lot of promise, so we're very excited about that. Just 2 program or funding opportunities to mention. Number one, there's a opportunity for advancing research in acute flaccid myelitis that's tangentially related, but certainly of interest to everybody in this room. So there's new applications being accepted to support both basic translational and clinical research on that field. And lastly, as usual, there's an active program announcement for advancement of research to advance vaccine safety. This has been going on since 2009, and there's multiple awards for that. The links to all these trials, the links to all these funding announcements will be provided for the minutes. Thank you.
Good morning. I'm Narayan Nair. I was going to provide the update on the National Vaccine Injury Compensation Program, and we're continuing to process an increased number of claims. Last fiscal year, FY 2018, we received 1,243 claims. In that fiscal year, we awarded $226 million to petitioners and $26.9 million to attorneys, and that includes fees to attorneys for cases that are compensated, dismissed, or also interim fees. For this fiscal year, as of February 1st, we have 411 claims have been filed, and $74.4 million have been awarded to petitioners and for attorneys' fees. Because of the increased number of claims that we've seen in recent years, we do have a backlog of 726 claims that are awaiting review by our medical officers. And more data about our program can be obtained on our website. And just to provide the broad picture for our program, from 2006 to 2017, we received 6,000 petitions that were adjudicated. Of those, 4,000 were compensated, so roughly 70% of claims are compensated. In that same time period, according to CDC data, about 3.4 billion doses of vaccine were distributed in the U.S. So approximately for every 1 million doses of vaccine that's distributed, we compensate one claim. And that concludes my update.
Doran Fink for FDA Office of Vaccines. So in terms of notable approvals since the last meeting of the ACIP, you already heard about 2 of these yesterday. Vaxelis, the hexavalent pediatric vaccine indicated for use in children 6 weeks to 4 years of age, was approved in December of 2018. And a 0.5 ml dose of Fluzone seasonal inactivated influenza vaccine was approved for use in children 6 months to 35 months of age. That was in January. One approval that you haven't heard about yet is for Adacel, tetanus, diphtheria, and acellular pertussis booster vaccine. In January, FDA approved use of a second dose of Adacel in individuals who received a first dose of either Adacel or another tetanus, diphtheria, and acellular pertussis vaccine at least 8 years prior, or in the case of wound management, at least 5 years prior. And then in other FDA news, coming up next week at the White Oak campus in Silver Spring, Maryland, we will have our Vaccines and Related Biological Products Advisory Committee. On March 6th, as mentioned yesterday, we will be discussing strain selection for the 2019-2020 seasonal influenza vaccines. Also, as mentioned yesterday, we are still waiting on the WHO recommendation for the H3N2 strain component of those vaccines. So we will not be able to make a recommendation at our advisory committee meeting next week. We are committed to ensuring minimal downstream effects on influenza vaccine availability for the 2019-2020 season, and we hope to have additional information about next steps at our advisory committee meeting next week. The next day, on March 7th, we will be discussing the safety and effectiveness of Dengvaxia, which is a live attenuated dengue vaccine intended for use in individuals 9 through 45 years of age with laboratory-confirmed prior dengue infection and living in endemic areas. Thank you.
Thank you.
Good morning. Eric Dusing for the Department of Defense. Excuse me. The Department of Defense appreciates ACIP and CDC's continued inclusion of the DoD in this meeting and the ACIP working groups. I have 3 brief updates from the Department of Defense for ACIP's awareness. First, regarding yellow fever vaccine, like so many others, DoD is happy to learn of the new yellow fever vaccine form fill facility that has been approved by CBER, our colleagues at FDA, and awaits arrival of vaccine supply. It's anticipated that DoD will continue its current restrictions of yellow fever vaccine utilization until the nationwide vaccine supply exceeds demand. The second update is with respect to influenza vaccine effectiveness. DoD researchers have initiated a study called the Pragmatic Assessment of Influenza Vaccine Effectiveness in the DoD, also referred to as the PAVED study. This IRB-approved study assesses influenza vaccine effectiveness among egg-derived, cell culture-derived, and recombinant protein vaccines. Per protocol, the available licensed vaccines were randomly allocated to consenting volunteers who presented to receive influenza vaccine. These individuals are being followed to assess whether influenza attack rates differ based upon vaccine received. And this study began in the fall of the 2018-2019 season across several DoD sites in the U.S. Finally, a note with respect to vaccine redistribution. Vaccine redistribution in the DoD continues to be a widely successful program. Individual DoD immunization sites have the capability to communicate near expiring vaccine surplus or a vaccine deficit through personnel at the immunization healthcare branch at the Defense Health Agency. IHB staff then can reach out to other immunization sites to redistribute vaccine as needed. In fiscal year 2018, $740,000 worth of vaccine were successfully redistributed using this mechanism. Thank you for this opportunity to update ACIP.
Thank you.
Good morning, Tom Weiser from the Indian Health Service. The Indian Health Service has held regular calls and area and local immunization coordinators and clinicians to promote the influenza vaccine uptake for this year. Throughout our influenza surveillance system, we estimate that we've administered at least 295,000 doses of flu vaccine with a population coverage estimate of about 35% among those 6 months and older. Uptake was highest among our vulnerable populations, young children and elders. Among children 6 to 23 months of age, about 58% received at least one dose of flu vaccine, and for elders 65 and older, 49% received a flu vaccine this season. We have a mandatory influenza vaccination for healthcare workers policy, and this policy requires that healthcare employees receive the flu vaccine each year, and we define healthcare employees as anyone working within the healthcare facility. So as of December 31st, 93% of all healthcare employees working for Indian Health Service had received their flu vaccination. The policy applies only to employees in facilities operated directly by Indian Health Service, not to tribally operated facilities or urban Indian health programs. But we do encourage those programs to adopt this policy, and many actually led the way for IHS by adopting it before we did. With regards to measles, the IHS has not been directly impacted by the current outbreaks of measles in the Pacific Northwest or in other parts of the country. But we have worked to get the word out about the benefits of measles vaccination with resources on our website. Our first dose MMR coverage among 19 to 35-month-olds is currently 86.5% as of December of 2018. Among our adolescents 13 to 17 years of age, 95.8% have received both doses of MMR vaccine. So we continue to push our efforts to vaccinate at all ages, both with influenza and with the routine schedule of vaccines. And finally, I'd just like to appreciate also the discussion that was held yesterday regarding the Hib vaccines for American Indian Alaska Native populations. We really appreciate that kind of attention, and thank you.
Thank you.
Good morning, Lori Hoffman-Hogue, representing Dr. Jane Kim, Department of Veterans Affairs. Over 1.8 million veterans received free flu shots during the fiscal year 2018. VA continues to partner with Walgreens during the current 2018-2019 flu season. This partnership resulted in over 105,000 vaccines paid for by the VA during the 2017-2018 flu season. VA also released an updated National Electronic Decision Support Tool, also called National Clinical Reminder, for hepatitis B immunization. This clinical reminder can be used in VISTA, the VA electronic medical record. VA continues to align electronic measures with HEDIS. When we compare VA to HEDIS, HEDIS technically captures flu via survey methodology. VA collects using both survey and chart abstraction. VA exceeds HEDIS measures for flu shots for both adults aged 18 to 64 and 65 and older. Thank you. That concludes my report.
Thank you. All right, so now we'll move on to the pneumococcal vaccines with an introduction by Dr. Lee.
Thanks very much. Pleased to start us off on day 2. Would like to thank the work group members for the pneumococcal vaccine work group My co-ACIP members, Kip Talbot and Paul Hunter, our CDC leads, Tamara Pilishvili, I always say it, apologies, and Almia Matanak. And then I actually really want to thank our liaison representatives and consultants. We've had some really interesting, robust, thoughtful conversations, particularly in recent months. And everyone in this group has contributed their knowledge, their time, and their expertise to really help us think about how to make the best possible decisions. So thank you to all of them as well. The terms of reference for this work group are to review the current data on efficacy, effectiveness, immunogenicity, and cost-effectiveness of pneumococcal vaccines. Our job is to review current recommendations considering up-to-date evidence, including epidemiologic studies, and assess the strength of that evidence, and then revise or update recommendations for pneumococcal vaccine use as needed. So this timeline shows the recommendations made by ACIP over the past 2 decades. PCV7 was first licensed for children in 2000 and then was replaced by PCV13 in 2010. In 2012 to 13, PCV13 was recommended for individuals with immunocompromising conditions. And then in 2014, PCV13 was recommended in series with PPSV23 for adults 65 and older, and this was all adults 65 and older. And we are now currently reevaluating that recommendation from 2014. So going back to the rationale for this, when ACIP recommended PCV13 in series with PPSV23 for adults in 65 and older, the rationale was that the recommendation was warranted in the short term because there was still a significant burden of disease among older adults, and particularly due to pneumococcal pneumonia. The public health benefits in the long term, however, were expected to be limited since the indirect effects from pediatric PCV13 use were expected to increase. Therefore, the recommendation was made with a commitment to reevaluate this policy 4 years later, or about 4.5 years in, and revise as needed. The policy question we're examining is, should PCV13 be administered routinely to all immunocompetent adults age 65 and older in the context of indirect effects from the PCV program experienced to date? So the population of interest are immunocompetent adults 65 and older with and without chronic medical conditions, but not the immunocompromised population. The intervention is PCV13 in series with PPSV23 in the context of indirect effects. And the comparison is PPSV23 alone, again, in the context of indirect effects. Our core outcomes are invasive pneumococcal disease, pneumonia, mortality, and safety. So this table is meant to emphasize, again, that we are not reconsidering the recommendation for those considered at highest risk, so the immunocompromised population, so in the darker orange. The population of interest that we're focused on is outlined in red, again, adults 65 and older with and without chronic medical conditions. During today's pneumococcal session, you'll hear about PCV13 direct and indirect effects on serotype 3 disease, PCV13 direct effects on pneumonia hospitalizations in adults, a comparison of economic analyses of PCV13 use among adults 65 and older, and grade and evidence to recommendations, discussions that we've had regarding PCV13 use among adults 65 and older in the setting of sustained indirect effects. So, since our goal is transparency in the decision-making process, we would like ACIP members to consider the following. So first, what is the balance of desirable and undesirable effects of PCV13 use in immunocompetent adults over 65 in the context of indirect effects from the pediatric program? After we've thought through that, then we're going to ask you to consider values, acceptability, resource use, and implementation issues, and think about what your overall assessment of continued PCV13 use in immunocompetent adults would be for those 65 and older. We'd also like to acknowledge head-on some of the really unique challenges that are posed by this particular decision. So first, although we're focused on the adult decision today, the working group wanted to emphasize that the pediatric vaccine programs are far more effective at reducing the overall burden of disease, pneumococcal disease, due to vaccine-type strains. And some of our members in the work group have found it challenging to consider these recommendations incrementally rather than holistically. Nonetheless, we'd like you to consider and focus on the particular question we're asking today. So just wanted to put that out there. The second challenge to this work group has been the issue of framing bias. So even though the health and economic impact of the intervention remains the same, whether we're implementing or de-implementing a recommendation, some of our work group members really feel that it's harder to make the decision when it's framed as a loss instead of a gain. And then finally, the work group is also aware of potential new vaccines that will require us to reevaluate this recommendation again in the future. So our job today on ACIP is to ask what additional information you might need that is also available today to help determine whether continued PCV13 use in adults 65 and older is warranted. In terms of the near future pneumococcal conjugate vaccine products, there are 2 new products in phase 3 trials. Both are PCV15 and PCV20. So both are conjugated to CRM197. Both are working towards licensure in adults first, not children. PCV15 includes PCV13 serotypes plus 22F and 33F, and it's currently in adult phase 3 trials. The manufacturer is projecting adult phase 3 trial completion by third quarter 2020, and this is based on information currently posted on clinicaltrials.gov. For the PCV20 product, it's PCV13 plus 8, 10A, 11A, 12F, 15B, 22F, and 33F. It's also currently in adult phase 3 trials, and the manufacturer is projecting adult phase 3 completion by the end of 2019 or early 2020. So with that, I'd like to invite Dr. Tamar Pilishvili up to speak to the PCV13 direct and indirect effects on serotype 3 disease. Thank you.
All right. Thank you, Stephanie. And thank you, Dr. Lee, for the introductory statement. And good morning, everyone. So I'll start by explaining the rationale. Why are we focusing on serotype 3? And specifically serotype 3 out of the 13 serotypes that the vaccine covers. So serotype 3 causes most of the remaining PCV13 type disease burden in the US and countries using PCV13. Evidence on PCV13 effectiveness against serotype 3 disease is not consistent across settings and studies. And assumptions around PCV13 effects on serotype 3 disease and effectiveness influence the expected impact and results of the economic analysis that we have presented so far and that you're going to see later in the session. A couple of background notes on serotype 3 pneumococcal strains. They have unique genetic, phenotypic, physiologic characteristics associated with invasiveness and disease severity. There have been temporal variations in incidence of serotype 3 disease reported, not related to the vaccine introduction. To date, in the literature, there are various mechanisms by which reduced effectiveness against serotype 3 disease is explained. Animal model studies have demonstrated that its very thick mucoid capsule was shown to release free polysaccharide, and that interferes with the antibody-mediated bacterial killing and protection. It has also been shown that there's a reduced opsonophagocytosis due to increased thickness and density of the polysaccharide capsule. This study was conducted in UK, and the primary objective of the study by Andrews et al. Was to evaluate effectiveness of PCV13 against individual serotypes using indirect cohort analyses. And in this study, they measured the effectiveness against serotype 3 to be 26%, with a very wide confidence interval, negative 69 to 68. But as part of this study, the investigators also reevaluated the serologic thresholds for protection, and they reevaluated them on a serotype-specific basis, as opposed to the accepted 0.35 threshold, which is an aggregate for all serotypes. So what they estimated is for serotype 3, the threshold of protection was 2.83, and it was much higher than for other PCV13 serotypes, which ranged from 0.16 to 1. And it is known that the threshold for protection against acquisition of nasopharyngeal carriage is much higher than that for IPD, which is what they estimated in the studies, and which is what 0.35 aggregate refers to. And the studies have to date have shown that there is no really impact of PCV13 on acquisition of the carriage for serotype 3, and most of the studies showed lack of impact on carriage. And therefore, no herd effects are expected from the childhood PCV programs. So in the next set of slides, what I will do is I will summarize what we know in terms of PCV effects on IPD caused by serotype 3. I'll present studies on effectiveness in children, population level, impact in children and adults, so direct and indirect effects at the population level, as well as what we know in terms of effectiveness in adults. The summarized on these slides are effectiveness studies for PCV13, specifically looking at serotype 3 IPD in children. So out of 6 studies that are presented here that were conducted in various countries, only 2 were able to demonstrate significant effectiveness against serotype 3. And one of these, our very own U.S. study that showed 80% effectiveness with 1 or more doses for children under 5 years of age, was conducted during the time when we were transitioning from PCV7 to PCV13. So most of the children in this study received toddler doses of PCV13. So it's a little bit of an apples and oranges comparison when you look across the studies of how children were receiving PCV13 in these effectiveness studies. The study from Europe that comes from the multi-center network on an invasive pneumococcal disease surveillance looked also, in addition to looking at the effectiveness by serotype, they also evaluated effectiveness by time since the last dose of the vaccine received. And even though for PCV7 serotypes as a group, PCV13 serotypes as a group, as well as 19A at the bottom, they showed the effectiveness was similar, less than 12 months since the last dose, as well as post 12 months after the last dose. For serotype 3, they showed that there may be some evidence of waning of the protection, where less than 12 months after the last dose, the effectiveness was measured at 73% and was significant, whereas more than 12 months after the last dose, it was 30%, and the estimate didn't reach statistical significance. Just recently, this February of 2019, WHO released a revised statement on pneumococcal vaccine use in children. This statement was informed by a very large body of evidence through systematic review of primary evidence on immunogenicity and effectiveness against invasive disease, pneumonia, carriage, and for 2 products that are currently available in the world, PCV10 and PCV13. The studies were evaluated. So I have a little excerpt here from that comes directly from the position statement that relates to PCV13 effects on serotype 3 invasive disease, which states that despite immunogenicity data showing immune response, there's evidence for a direct or indirect reduction in IPD due to serotype 3 after administration of PCV13 was inconclusive, although most studies showed no effect. And this evidence included both effectiveness as well as impact studies. Now, I would like to point out that PCV10 does not contain serotypes 3, 19A, and 6A. And as, in the statement related to the product choice in the same position statement, both PCV10 and PCV13 have substantial impacts against pneumonia for vaccine type as a group, IPD and carriage. However, PCV13 may have an additional benefit in settings where disease is attributable to 19A and serotype 6C is significant, and yet no mention of serotype 3 because of the statement above. This is the data that we have shared with the committee, comes from active bacterial core surveillance system. We have updated it through 2017. we have seen dramatic reductions in the incidence of vaccine serotypes among children under 5. And here presented is by individual serotype. As you can see, most of the reductions were driven by serotype 19A, but we saw significant reductions in serotype 7F, as well as the cross-reactive serotype 6C. But serotype 3 presented here in the green line, we have seen overall annual changes, but no net impact on serotype 3 disease. We saw non-significant 31% reduction if we look strictly at before versus after vaccine introduction. We also wanted to understand whether there are any long-term changes in serotype 3 disease in children. So we looked at a longer time scale from 98 before PCV7 was introduced all the way through 2017. And we also, instead of trying to attribute any changes to the vaccine introduction, we wanted to understand where the changes in serotype 3 disease trends occurred, and conducted this joint point analysis, which essentially allows the data to tell us where the point of inflection in data is. So what we found is that the serotype 3 rates, it seemed to have been increasing before PCV7 introduction, and then sometime in 2003 with a wide confidence interval that actually does not include the PCV13 introduction timeline, where we have seen reductions in type 3 disease. But that trend started way before PCV13 was introduced in the US. This is a study from the same European network that I mentioned before, this time now looking at the impact at a population level from various countries that are using PCV13 on the left, as well as countries that are using PCV10. And as I mentioned, PCV10 does not contain serotype 3. And what this analysis also showed is that in countries that are using exclusively PCV13, they initially saw what appeared to be reductions in serotype 3 disease. And I know it's very hard to see, but it's a black line at the bottom. But then since 2014, they've actually seen increases in serotype 3 in PCV13 countries. Whereas in countries that are using PCV10, and 2 of them actually have combination PCV10 and 13, they've seen no changes in serotype 3 during the entire time period. What about impact and indirect effects in adults? So again, from the same network, this is analysis looking at the indirect effects on serotype 3 IPD among adults 65 and older. Sites that are using PCV13 exclusively as part of the pediatric program are presented on the left, and sites that are using PCV10 are on the right. And very similar picture to what they saw in terms of direct effects on disease in children. Here presented are rate ratios that are comparing incidence in each year to the pre-vaccine baseline. So what they observed is through 2014, as you can see, the rate ratios are below 1. So there was an indication that there might be a reduction in type 3 disease. However, since 2014, they have seen increases again back to the same levels, so that the net change is a 12% increase in rates of serotype 3 disease. While in PCV10 countries, what appears to be, it has been more of a steady increase in serotype 3 disease, although the confidence intervals are very wide because there are fewer sites included in this analysis. The U.S. data, again, shows a very similar picture what other settings using PCV13 have demonstrated in terms of indirect effects, which would be between the years of 2010 and 2014. We've seen reductions in all PCV13 serotypes, with the exception of serotype 3, through indirect effects. And then following the adult vaccine introduction in 2014, as you can see, annual changes, which are less than 1 case per 100,000, but overall, there has been no change on serotype 3 disease even after the 2014 recommendations. And we had conducted a similar analysis also for adults to see where the change in serotype 3 occurred. And we see a very similar picture where it seems like there's a natural cycle where the disease incidence might have started decreasing sometime before even PCV7 was introduced, and that trend continues. And what the epidemiology shows in recent years is that in 2016, 2017, serotype 3 causes most of the invasive disease infections in adults 65 and older. All of the vaccine serotypes, they don't rank anymore as top 10 serotypes. We also tried to look at our surveillance data and understand what is the contribution of the direct versus indirect effects to the observed trends that I showed on previous slides. So we constructed a mathematical model that uses the coverage data as well as the surveillance data incidence data before the vaccine was introduced, as well as after the vaccine is introduced. This is a model that I actually described a couple of meetings ago, which took probably 5 slides to describe. But what I wanted to point out is the bottom line results from that mathematical model, which are in the last column. In terms of the U.S. cases averted due to direct effects of PCV13 use in adults. So when we look at the PCV13 type cases and plus include also 6C cross-reactive serotype, we measured that there were over this period of time from August 2014 through May 2017, 190 cases averted and very wide confidence interval suggesting there may be no change. In the same model, when we excluded serotype 3, that's where the benefits of the direct use of the vaccine appeared, where we are estimating that there were 580 cases prevented and a significant confidence interval. So again, serotype 3 seems to be diluting our ability to look at, evaluate the direct impact on adult disease. A case control study evaluating PCV13 effectiveness among U.S. Medicare beneficiaries 65 years or older by vaccine serotype group is presented here. This study addressed different serotype groups, looking at PCV13 serotypes as a group, and also PCV13 serotypes when we exclude serotype 3, but we also had power to look at the effectiveness for serotype 3 alone. And for PCV13 serotypes without serotype 3, the estimate is 67% and significant confidence interval. For serotype 3 alone, the estimate was lower, 26%, and it didn't reach statistical significance. Presented here are results from a post hoc analysis of the CAPITA trial in the Netherlands, randomized control trial. Now, this trial was, the objective was to evaluate effectiveness against vaccine type community-acquired pneumonia. So invasive disease was not the primary target of this trial, nor was to look at the serotype-specific effectiveness. So this study was underpowered, obviously, to look at the serotype 3 invasive disease. But then, nevertheless, if you look at, there were 0 cases in a PCV13 arm and 4 cases in a control arm, which would translate into 100% efficacy, but obviously confidence interval is not significant because study was not powered to look at that. And now moving on to PCV13 effects on pneumonia caused by serotype 3. There are limited studies available that evaluate serotype-specific pneumonia burden and vaccine effectiveness because there's no commercially available test to detect pneumococcal serotypes causing non-bacteremic pneumonia. What I'll present in the next few slides are studies utilizing Pfizer-developed serotype-specific urine antigen tests, which are the only studies that can look at the specific outcome. Again, the same CAPITA trial in Netherlands, in the original trial population for per protocol analysis for serotype 3 community-acquired pneumonia. Effectiveness was 56%, but the 95% confidence interval didn't reach across the null value. And for modified intent-to-treat analysis, where they included individuals, subjects that later developed immune compromise or other protocol violations, which would have excluded them from per protocol analysis, the effectiveness was 60%, and confidence intervals was significant, 5 to 85. Another post hoc analysis from the CAPITA also trial in the same population, in this time looking at all clinical CAP and not just the X-ray confirmed as it was in the original trial, showed close to 62% effectiveness and a confidence interval ranging from 18 to 83. Test negative design case control study, which was presented to this committee a couple of meetings ago, which is nested within Louisville pneumonia surveillance, has demonstrated effectiveness of 52%, close to 53% against serotype 3 community-acquired pneumonia, hospitalized pneumonia, but the confidence interval is very wide from that study. And as part of the same Louisville study that I mentioned, which is a surveillance for hospitalized pneumonia, it's a Pfizer-supported surveillance. Again, this study was presented a couple of meetings ago and demonstrated 13% reduction in all-cause community-acquired pneumonia and a 31% reduction in PCV13 type community-acquired pneumonia. From the same population, although looking at a little bit of a different shift in a timeline, although covering the same respiratory season from October 14 to September 15, as opposed to June 2014 to May 2015, as for PCV13 type data presented, the proportion of serotype 3 disease out of all CAP was 0.78% reported. Now, in the time period the following year, October 2015 to September 2016, the proportion of all CAP that was serotype 3 was reported as 1.26%. So if we apply these percentages to the incidence of all cause CAP, what we get is 18 cases per 100 or 19 cases per 100,000 for serotype 3 CAP incidence, and the subsequent year 26.2 per 100,000, and that was in a setting of around 36% PCV13 coverage. So what you see is even though there was a reduction in PCV13 type CAP reported, there doesn't seem to be the same trend for serotype 3 incidence in the same population. And if we do a little like a back of the envelope estimation, and this actually relates to what we see in invasive disease, where there may be some effectiveness, but we're not seeing at a population level any impact. It seems to be the same trend for the pneumonia data as well. So if we take the baseline incidence and multiply it by the vaccine efficacy that is estimated from the clinical trial, also take into account the coverage of the vaccine, what would we expect is incidence of around 15 cases per 100,000 in a setting of this level of coverage. However, what we're seeing is 26.2 cases per 100,000. Again, this was like a back of the envelope calculation that was done based on the data that we received from Pfizer. And now to summarize what I just presented. So in children, in terms of PCV13 effectiveness against serotype 3 invasive disease, there's inconsistent findings with most studies showing no effectiveness. It seems to be the duration of protection maybe shorter for serotype 3 than for other vaccine serotypes. And also at least a couple of comparisons that are in the literature, including the study that I highlighted in the US, suggest that maybe toddler doses may be working better than infant series followed by a toddler dose. There's no population-level impact on serotype 3 invasive disease demonstrated in the U.S. and countries using PCV13. What we know in adults in terms of effectiveness against serotype 3 IPD, we show non-statistically significant VE in CAPITA, although post-hoc analysis, although that study was not powered to look at serotype 3. The case control study in the US was powered to look at it and showed low effectiveness and non-significant effectiveness estimate. We see no population-level impact on serotype 3 IPD in the US or countries using PCV13 among adults, whether it's indirect or direct effects. And in terms of PCV13 effectiveness against serotype 3 pneumonia, the studies, CAPITA and one observational study demonstrated effectiveness, but from two of the analyses, non-significant estimate, and significant effectiveness was demonstrated in a post-hoc analysis of CAPITA and modified intent to treat analysis. And from the limited data that we have on the population level impact on serotype 3 pneumonia, at least from one cohort study suggests that there may be no population level impact on serotype 3 pneumonia in a setting of around 36% coverage. So in conclusion, PCV13 may provide some level of direct protection against invasive disease and pneumonia caused by serotype 3. There are inconsistent findings across studies. Effectiveness is lower as compared to other PCV13 serotypes. Given these vaccine effectiveness measures, the point estimates or the significant estimates that are measured in some studies, and given the coverage that we achieved to date, some population level impact is expected. However, we have seen no population level impact on serotype 3 disease to date. And that can be related to limited duration of protection. We know that there's no impact on carriage, so there's continued circulations of these strains in the community, and with a sufficient number of susceptible individuals being exposed, that may lead to the disease rates persisting. And there's high level of uncertainty remains in terms of the expected benefits from the PCV13 use on serotype 3 disease. And therefore, the work group felt that the assumptions around the inputs for vaccine effectiveness against serotype 3 disease are influential for models estimating expected public health benefits from PCV13 use in adults. And therefore, the work group felt that a range of values needs to be considered, which ranges from no effectiveness, which was presented earlier as a base case to the committee, as well as an alternative analysis where we do assume some effectiveness based on the studies that report significant effectiveness. And you're going to see some of these ranges taken into account for the analysis that will be presented later in the session. So I'm going to stop at that, and I don't know if I have questions.
Questions from the committee. Dr. Grabstein.
Hi, great presentation, thank you. I'm wondering if there's any other way to look at attenuation of disease, for example, with serotype 3, if there's some residual benefit, and one way to do that might be looking at cost. In your Medicare beneficiaries, you would have a cost profile that you could look at to see if, even if they got pneumonia, maybe they had fewer hospital days or some other unmeasured effect.
If I understand correctly, you're asking more about the impact that on severity that it might have and the
Correct.
Duration. Yes, we could look through the CMS data as well as our IPD data for hospitalized cases. Yes, thank you.
Dr. Stevens.
So I'd like to explore a little bit the difference between the earlier U.S. and Germany studies that showed significant effectiveness versus the ones that show little effectiveness. And you mentioned that you think that's related to the toddler catch-up campaign. Is that correct? Could you just elaborate on why you think there is such a difference in those data?
So I think that the schedule is as one of the hypotheses that has been raised. In terms of the populations in those studies that I presented, for the studies in UK and some of the other ones that did not reach the statistical significance, it was clear that they were able to look at the schedule with the infant 2 doses, at least 2 doses, followed by a booster. So it's clear which populations they're evaluating, and they're not finding significant, there are no significant findings from those studies. From the 2 studies that reported significant vaccine effectiveness I can only conclusively say about the US, which was clearly a very different population from, let's say, UK study, because of the transition between 7 and 13 vaccine. Most of the children in that group where we looked at the vaccine effectiveness against serotype 3 were immunized with the toddler schedules, and that has been raised as a hypothesis, but I don't think we have a lot of data to support that hypothesis.
Dr. Bernstein.
Along those lines, on slide 12, it seemed that in the network that was used in the European Union, it seemed that for the first several years in those countries that were, the next slide, 12, yeah. It seemed that between 11 and 14, the PCV13 countries, it seemed to be having a positive effect and then started to rise, and those that are with the PCV10 on the right. And what is your explanation for those 4 years where it seemed to be having an impact?
So the investigators explain it as it was probably due to some natural variation that they saw this reduction, and then now they attributed it to the vaccine initially. When the initial findings were reported, they attributed to the vaccine use and indirect effects. But now that they see an increase, they attributed it to the perhaps natural variation in a serotype 3 incidence that coincided with the trends that they're evaluating. And the data that I showed also for the US seems to suggest that, we do see this, it's not annual variation, but every so many years there seems to be a dip, but then an increase. But we did see this increase before BCV7 and then the reduction. So if we were to compare 2 time periods in the US data, pre and post-vaccine, you would actually attribute it to the vaccine and measure it as a vaccine impact. However, if you look at the longer-term trends and see that the disease was already on a decline, then it's harder to attribute it to the vaccine, and probably some combination, including mostly driven by natural variations in serotype 3 disease.
So you would expect it to mirror what's being seen in the countries that are using PCV10 then?
So for countries with PCV10, they did see more consistent increases, but you can see the confidence intervals are very wide. So I'm not sure that I can say like what related it directly to the PCV13.
Thank you.
Any other questions from the committee? Okay, we're going to move on to the next topic. PCV13 direct effects on pneumonia, hospitalizations in adults. Dr. Lessa.
Hi, good morning. So I'll be talking about analyses CDC performed in partnership with ACIP and CMS to evaluate the impact of the new PCV13 recommendation in adults on pneumonia hospitalizations. However, before I start, I really want to acknowledge the ACIP team, who is a CMS contractor, and my CDC coworker, Trey Spiller, for their dedication and commitment to this very complex analytical project for the last 8 months. So our project goal was to evaluate the direct effect of PCV13 on pneumonia hospitalizations among persons 65 and older, given the new PCV13 recommendation among U.S. adults. To address our project objective, we used CMS Medicare Part A and B data. Our study cohort included all Part A and B beneficiaries who were 65 years of age and older on September 1st, 2014. After September 1st, 2014, only beneficiaries were enrolled in Part A and B within 6 months of their 65th birthday were included in the cohort. Beneficiaries were observed until December 31st, 2017, unless they died, moved out of the United States, disenrolled from Part A and B, or developed the outcome of interest before the end of our observation period. Pneumococcal vaccination status was divided into 4 categories: PCV13 only, PPSV 23 only, both vaccines, or no pneumococcal vaccine. We use inpatient, outpatient, and physician Part B claims to stratify the CMS Part A and B beneficiaries into 4 mutually exclusive risk categories based on their underlying conditions and according to the previous risk-based pneumococcal vaccine recommendation for adults. The 4 mutually exclusive groups were high-risk 1 only, high-risk 2 only, both high-risk 1 and high-risk 2, and low risk. The conditions highlighted in red were the most prevalent conditions, with a special attention to diabetes and chronic lung disease, for which the prevalence was around 42% in the CMS Medicare Part A and B population. Therefore, as you can imagine, a lot of the individuals with high-risk 1 plus high-risk 2 conditions were likely to be those with diabetes and chronic kidney disease, or those with chronic lung disease and some iatrogenic immunosuppression. We evaluated 3 outcomes based on inpatient claims: community-acquired pneumonia, was defined based on discharge codes and previous published algorithm by Marie Griffin and colleagues. Non-healthcare associated CAP was defined as a CAP in a patient without an admission to a hospital or a skilled nursing facility in the 30 days prior and without a prior healthcare associated pneumonia hospitalization. Lobar pneumonia was defined as discharge codes of lobar pneumonia or pneumococcal pneumonia in any discharge position. We use discrete time survival model to calculate instantaneous hazard ratio, which is equivalent to incidence rate ratio. The outcome of interest was treated as a binary variable in each month of our study period. Generalized estimating equations, GE, was used to adjust for correlations with the assumption of proportional hazard. Vaccine effectiveness was calculated as 1 minus the incidence rate ratio multiplied by 100. We created 4 separate models stratified by influenza season and influenza vaccination status. Influenza season was defined as the months of October through April, while no-influenza season was the months of May through September. The rationale for the 4 models was related first to concerns with biological interaction between flu vaccine and secondary bacterial pneumonia, including pneumococcal pneumonia. Second, the observation the availability of the current data that shows that pneumococcal and influenza vaccines are not independent observations. PCV13 coverage goes up during the period that flu vaccine is available. And third, the current published influenza literature showing that underlying characteristics of flu-vaccinated individuals are different compared to flu-unvaccinated individuals. Each of the 4 models were adjusted for variables listed on this slide. These variables represented potential confounders related to immunization practices. For example, states with high incidence of CAP may have higher rates of PCV13 administration. We also adjusted for confounders related to selection bias on who receives the vaccine. For example, older and sick people may be more likely to receive PCV13 compared to younger and healthier adults. To calculate the number of hospitalizations averted, we first estimated the number of hospitalizations for each outcome in the absence of PCV13 using the observed number of episodes divided by the incidence rate ratio based on our models. And then we subtract this expected number in the absence of PCV by the number of observed episodes. This table describes the characteristics of the cohort at the beginning and the end of our observation period. At the beginning and the end of the cohort, we had 26.5 million and 24.1 million beneficiaries 65 and older, respectively. This represents approximately 57.6% of the US population 65 and older. Around 55% of the cohort was composed by individuals 65 to 74 years of age. Despite our study design to only allow persons who enroll in CMS Part A and B within 6 months of their 65th birthday after the start of the cohort, the age distribution did not change comparing the beginning to the end of our cohort. Male distribution was similar at the beginning and the end of our cohort. PCV13 use went from 0.8% in September 2014 to 41.5% in December 2017. In terms of high-risk categories, the distribution was similar at the beginning and at the end of the cohort, with the high-risk 1 only category being rare, around 5%. Most of the cohort were represented by either high-risk 2 only or high-risk 1 plus high-risk 2. Also, over 1/4 of the CMS Part A and B beneficiaries had severe underlying conditions as represented by the Charlson Index and frequent healthcare exposures. This graph shows you the characteristics of the beneficiaries who got PCV13 based on the last month of our study period. PCV-vaccinated individuals tended to be older, sicker, with more contact with healthcare setting, and substantially more likely to have received influenza vaccine compared to PCV13 unvaccinated adults. This graph shows the incidence of the three outcomes of interest per 100,000 person months. The average of CAP incidence across our study period was 148 per 100,000 person months. Non-healthcare associated CAP is a subset of CAP, and the average incidence was 115 per 100,000 person months. Lobar pneumonia was relatively rare, with an incidence of 6 per 100,000 person months. CAP incidence varied by age groups, ranging from 86 per 100,000 person months for age group 65 to 74, to 334 per 100,000 months for the age group 85 and older. CAP incidence also varied greatly by risk group. Those who had high risk 1 plus high risk 2 condition had CAP incidence almost 3 times higher compared to high risk 2 only, and 14 times higher compared to the low risk group. Now I'll move on to the model results. In order for you to understand the PCV13VE results I'm about to present, it is important to bear in mind the characteristics of the beneficiaries in each of the models. The flu season models had the largest number of total person months compared to non-flu season models. The proportion of the beneficiaries 65 to 74 years old for the models with flu-vaccinated individuals was around 48%, while that the models with flu-unvaccinated individuals, the age group 65 to 74 was around 59 to 62%. Similar pattern was seen in terms of the proportion of high risk 1 plus high risk 2 and low risk. While the models with flu-vaccinated individuals had 37% and 19% in the high risk 1 plus high risk 2 and the low risk categories respectively, the models with flu-vaccinated individuals had 28% of the individuals in the high risk 1 plus high risk 2 and approximately 33% of the individuals at the low risk. Therefore, the models with the flu-unvaccinated individuals represent a healthier group of elderly compared to the models with flu-vaccinated individuals. And I'll be using a lady riding a bike just to represent this healthier elderly group on the subsequent slides, so that's to remind you all of this group in each of the models. So this graph shows the PCV13 vaccine effectiveness against all-cause CAP across the 4 models. The VE point estimate ranged from 6% in the flu season flu-vaccinated to 11.4% in the flu season flu-unvaccinated. This graph shows you the PCV13 vaccine effectiveness against non-healthcare associated CAP across the 4 models. The VE point estimate ranged from 5% in the flu season flu-vaccinated to 11% in the flu season flu-unvaccinated. Finally, this graph shows the PCV13 vaccine effectiveness against lobar pneumonia. The VE point estimate ranged from 1.3% in the flu season flu-vaccinated to 11% in the flu season flu-unvaccinated. Based on our analysis, PCV13 averted 28,600 CAP hospitalizations, which included 18,700 non-healthcare associated CAP and 1,100 lobar pneumonia hospitalizations from September 2014 through December 2017. Of the 28,600 CAP hospitalizations averted, 18,700 were averted during the last year of our observation period, from January through December 2017. The reason for most CAP hospitalizations to be averted in the later years is probably related to the change in the risk distribution of the individuals who are getting the vaccine as PCV13 coverage goes up over time. As shown in this graph, you can see that the proportion of low-risk individuals, which is represented in yellow, who are getting PCV13 only, or both PCV13 plus PPSV, has gone up between 2014 and 2017. And this is likely the group that will benefit most of the vaccine. Our study has several limitations. Despite all our adjustments, we probably did not eliminate all the biases inherent to administrative data. It has been shown that ICD codes fail to remove all confounding in pharmacoepidemiologic studies among seniors. A major problem is the lack of reliable ICD codes to measure functional status. The adjustments we made for chronic conditions and healthcare utilization can reduce biases, but do not completely eliminate them. Also, based on the experience from hospitalized influenza VE network, the HAVEN network, and ABC surveillance, up to 30% of the individuals who had documentation of flu or PCV23 according to active surveillance were misclassified as unvaccinated in CMS data. Misclassification was uncommon for PCV13 vaccination status when ABC's data was compared to CMS data. In summary, CAP incidence is highest among individuals 85 years of age and older and those with high-risk 1 and high-risk 2 condition. Individuals who got PCV13 were older, sicker, and had more healthcare exposures compared to those that were unvaccinated. Effectiveness of PCV13 was observed against the first episode of CAP, no healthcare associated CAP, and lobar pneumonia. In conclusion, we found a VE for PCV13 against all-cause CAP to range from 6% to 11.4%, which is very similar to what Gessner and colleagues published doing a post-hoc analysis of the clinical trial data from the Netherlands, the CAPTA trial. Based on our analysis, approximately 28,600 CAP hospitalizations were prevented within 40 months after the implementation of the new PCV13 adult program in the United States. Of those, 65%, or 18,700, were prevented in the last 12 months of our study period. The large proportion of cases averted to be in 2017 is likely related to the change in the characteristics of the adults who are getting PCV13 in more recent years. However, it's important to note that this number of cases averted represented only 5.1% of all CAP hospitalizations. With that, I want to acknowledge all my collaborators. Thank you.
Questions or comments from the committee? Dr. Bernstein.
An amazing amount of work. Thank you. I think one of the questions that I have is how you do the risk adjustment. It's obviously a very complicated process to try to adjust for an unhealthy population and then comparing them to the others. One of the challenges, especially when you're working with Medicare claims, is when you're looking at hospitalizations as an outcome, I think you have to risk adjust for prior hospitalizations, and that might be a more effective strategy than just doing disease categories. So that's a suggestion of a way to look at this. Second thing is, I know that this focus was specific to CAP, but pneumonias also cause other outcomes. If, for example, 30% of hospitalized pneumonias also relate to cardiac events, and so that might be another outcome of interest that could be prevented with pneumococcal vaccination.
Thank you for your comments. Like in our model, we did adjust for a number of hospitalizations in the prior year. But I think that what your suggestion is maybe we can exclude those that had hospitalization the prior year, right? So is that your suggestion?
So I'm thinking of a prior event rate ratio as a specific approach.
And then, yeah, we could look at other outcomes as well. Yeah.
Thank you.
Dr. Bernstein.
Obesity plays a role in influenza disease as a high-risk condition. Have you found the same in invasive pneumococcal disease or pneumonia?
We did not look specifically at obesity. I'm not sure if in the IPG data, in the ABC data, you all have looked into that. But for this particular analysis, we did not. So that's a good point.
Dr. Stevens.
Can you help me sort out the effect of PCV 23 versus PCV 17 in this, the PCV 13 in this study? I mean, are they both getting both vaccines? What about what about the efficacy, if you will, of just the polysaccharide alone?
Yeah. So I'm not presenting that, but we did look into that. And the way that we looked at may not be the most appropriate way of looking at, because I think that there is a waning effect of PPSV23. And for our analysis, it was anyone who got PPSV23 in the last 5 years. So the other thing that we have found with this analysis is that the PPSV23 patient population is very, very, very sick. And even with our adjustments, we don't think that we really are able, because we don't have functional status, for example, which we know from the influenza studies that's really, really important to adjust for. We are not able to do that. So when we look at PPSV23 versus unvaccinated, we don't see an effect. But again, I don't think that the way we looked at is the most appropriate way for PPSV23, given the question that we had was for PCV13. So.
Thank you for a very nice presentation. I was interested in your later comments about your thoughts that the reason about the low-risk population. What percentage of all community-acquired pneumonias were from that low-risk population?
That's a good question. It is a small proportion that's among the low risk, but I don't have that on the top of my
But you're surmising that the increase in vaccination rates among that population might have accounted for some of these results.
For some of the VE results, yes. But yeah, I don't.
Even though they're unlikely to have being hospitalized from community-acquired pneumonia.
Yeah, the incidence is lower. Yeah, the incidence among them is lower. They may not represent a large group, but when you look at the VE overall and you stratify by the high-risk group, you can see that the VE is higher among this group of low risk.
You know, we think it's actually on one of your slides.
It is. It is. The VE is higher among that. Yeah, I can show you what, but it's not like exactly. I think that his question was more about the proportion of CAP. But as you can see in this slide, we put the VE across all the 4 modes for PCV13 only compared to unvaccinated. And you have the high risk 1 plus high risk 2 only, and low risk. And then you can see that across all the models, even though the low risk has this large confidence interval, and again, because they do represent the person months are smaller in this group, and then also the events, they have a lower number of events. But as you can see, consistently across all the 4 models, they had a higher VE compared to the high risk 1 and 2 and high risk 2.
The very wide confidence interval is obviously because there are far fewer hospitalizations from that group.
Yeah.
Okay, thanks.
Any other questions? The liaison groups? Dr. Rockwell.
Hi. I know this was really great, and to me it actually raises more questions than answers for me as an outpatient family physician, because those in the low-risk group who are least likely to be hospitalized do get diagnosed with pneumonia and get treated and get better, but we're not capturing all of them who might have benefit from the vaccine. That's my comment.
Thank you.
Any other comments, questions? All right. Thank you very much. So we'll move on now to the comparison of economic analysis of PCV13 use among adults greater than or equal to 65 years of age. Dr. Leitner.
So I'll be giving an overview of 3 economic analyses of pneumococcal vaccinations at age 65. This work summarizes the modeling work from 3 different teams, the CDC team, the Pfizer team, and the Pittsburgh team. Just want to acknowledge their efforts. Conflict of interest, I have none to declare. So by way of outline, I'll first provide introduction, talk about the study question, then I'll give an overview of some of the results. We will notice there are some differences in results across the models. So then we will look at some of the modeling assumptions to build an intuition for why some of these differences are occurring. We'll then move on to looking at health outcomes and cost results to confirm some of these intuitions. We will then further confirm and crystallize the intuitions when we look at the detailed cost results, especially the sensitivity analyses. And then we'll talk a little bit about a conclusion and summarize what we've learned. Okay, so I will, as stated, describe 3 cost-effectiveness models developed by 3 different teams. A presentation report for each of these models was given to the ACIP Pneumococcal Vaccines work group, and all 3 went through the CDC economic review process. The study question that we're interested in is, should PCV13 be administered routinely to all immunocompetent adults aged 65 years and older in the context of indirect effects from pediatric PCV use to date? So we will be looking at cost-effectiveness ratios that compare 2 strategies described here. The current recommendation, which is PCV and PPSV at age 65, and compared to an alternative, which is PPSV only. On some of the slides, I have to use some abbreviations just for space reasons. I'll try to say these words out during the talk, but I want to walk through one of these just to give us a feel for it. Third to the bottom row, this acronym stands for the vaccine effectiveness of PCV non-serotype 3 disease, where the disease type could be invasive pneumococcal or PCV type inpatient pneumonia or outpatient pneumonia. So moving on to an overview of some of the cost effectiveness results. We'll start with the CDC model. The current CDC base case estimates the cost per quality is $562,000 per quality. This is a adjustment from what you saw in October. The 2 parameters were updated: vaccine effectiveness and case fatality ratios, which resulted in a slightly lower cost effectiveness result here. We also supply a sensitivity analysis with higher vaccine effectiveness against PCV serotype 3 type disease. And this scenario will come up a few times because this turns out to be a very important parameter in the models. The Pfizer base case estimate is $199,000 per quality-adjusted life year. An alternate base case comes in at $186,000 per quality-adjusted life year. This scenario includes immunocompromised, but for the purposes of this summary presentation, we'll focus on the scenario that excludes the immunocompromised because the policy decision is more focused on the immunocompetent population, and it also brings the Pfizer scenario in closer alignment to what we use in the CDC model. In the Pittsburgh model, the base case cost effectiveness estimate is $765,000 per quality-adjusted life year. The Pittsburgh model was designed to investigate differences in Black and non-Black populations, and so I've included those results here as well. But for purposes of comparability to the other models, we are going to mainly talk about their total population result. Okay, on the left side, I'm just going to kind of reiterate the base case values from each of the models. On the right side, I will provide an overview of some of the main differences, and then we will go into more detail on these differences later. Relative to the CDC model, the Pfizer model has higher VE assumptions against PCV. Most importantly is the assumption against serotype 3 disease. They also have more severe case assumptions, by which I mean there is a higher quality loss per case and also higher case fatality ratios. They also assume lower indirect effects from the childhood program. The Pittsburgh model assumes higher VE for PPSV, and that's one of the main reasons that the Pittsburgh model estimate is higher than the other 2 estimates in the base case. The Pittsburgh model also assumes no indirect effects, making it slightly less comparable to the other 2, and they do a more detailed modeling of Black and non-Black populations. Okay, so we've seen some differences between the three models. Now I'm going to dive into a few of the most important modeling assumptions. The first is vaccine effectiveness, which is so important it gets its own 2 slides. So I'll skip that for now, and we'll move on to indirect effects. The CDC model assumes a 4.1% decline in incidences that are affected by the indirect effects every year until the model ends. The Pfizer model assumes the same 4.1%, but only for the first 3 years of the model, and the Pittsburgh model has none. For utility loss per IPD and per inpatient pneumonia case, the Pfizer model assumptions are higher than the CDC model and the Pittsburgh model. CDC model has the lowest. And for case fatality ratios, the thing to notice is that the Pfizer model has higher case fatality ratios than the CDC model and the Pittsburgh model as well. In the next few slides, we'll talk about vaccine effectiveness. On the left-hand side is vaccine effectiveness against non-serotype 3 pneumonia. On the right-hand side is vaccine effectiveness against serotype 3 pneumonia. Notice the Pfizer model assumes about 10% more vaccine effectiveness in the first 5 years of the model. After that 5-year mark, they both converge to 0 after 20 years. For serotype 3 disease, the Pfizer model assumes the same thing it did in the non-serotype 3 case, so about 40% for 5 years and then declining. CDC model in its base case assumes 0% effectiveness for serotype 3 pneumonia. In that sensitivity analysis that I mentioned earlier, called CDC higher VE ST3, in that scenario, this assumption is increased to about 45%, so a little bit higher than what is in the Pfizer base case for 5 years, and then it declines. A similar story with IPD. The Pfizer model assumes about 10% more VE in the first 5 years, then they both converge to 0 at age 85. And the Pfizer model assumes a base case of 26% VE for the first 5 years, then it declines. And the CDC model assumes 0% in the base case. Again, in that sensitivity analysis where the CDC model has higher VE against serotype 3, in that scenario, the CDC assumption is exactly the same as the Pfizer assumption for IPD. Okay, so those were the assumptions we've looked at. Now we're going to try to confirm what we think is going on based on the differences in assumptions with looking at some results. And we'll start with health outcomes. What to notice here is that comparing the within model inpatient burden of disease, or I should say burden averted, the inpatient pneumonia cases are much higher in the CDC model and in the Pfizer model. So inpatient disease is more important in these models than IPD, or I'm sorry, inpatient pneumonia is more important than IPD. A similar story for the averted deaths. A greater number of deaths are predicted in all three models that is due to pneumonia as opposed to deaths due to IPD. Here we can kind of compare across models. These are QALYs gained in each of the models. Pfizer has the highest number, and again, that is due to a higher QALY loss estimate assumption per case and a higher case fatality ratio per case, as well as higher vaccine effectiveness, which averts more of these cases. Moving to more detailed look at some of the cost effectiveness ratios. Just to recap, the base case values are on the left-hand side, and we're first going to look at vaccine effectiveness assumptions, and then we'll follow that up with these other factors. So in the Pfizer base case is represented by this top row blue bar. When the Pfizer model assumes the CDC assumptions on vaccine effectiveness, the cost effectiveness ratio goes from their base case of about $200,000 per QALY to about $590,000 per QALY. And this increase is due in most part to serotype 3 pneumonia, in least part to serotype 3 IPD, and the second most important category is non-serotype 3 IPD and pneumonia. The mirror image of that exercise done from the CDC model perspective. The top row here is the CDC model base case, and the bottom row is when the CDC model assumed a higher vaccine effectiveness against serotype 3, which brings it closer to, but not exactly the same as the Pfizer VE assumptions. And what you notice is that the base case cost effectiveness ratio declines to, I think it is $222,000 per quality, putting it very close to the Pfizer base case estimate. So less important than vaccine effectiveness, but still in the important category of inputs are the following. This is the base case for the Pfizer model, and here we impose in the Pfizer model the CDC assumptions on indirect effects, utilities, and case fatality ratios. And notice that in all these cases, the cost effectiveness ratio estimate increases, but not quite as dramatically as when we changed vaccine effectiveness. Same thing from the CDC model perspective. When the Pfizer model assumptions on indirect effects, utility, and CFRs are imposed in the CDC model, the cost effectiveness ratios decline, most in CFR, but even in CFR, not as much as when we impose the different VE assumptions. All right. So this graph is going to eventually summarize a lot of the one-way and multi-way sensitivity analyses in the reports. And as an example, these are all one-way sensitivity analyses. A multi-way would be if you changed CFRs and utilities at the same time, or any combination of the parameters changing at the same time. These 3 points are the base cases for the model. And these are the ranges that were observed in when looking at all of the one-way and all of the multi-way sensitivity analyses. And the main takeaway from this image is the CDC model and the Pittsburgh model have a lot more variability and uncertainty in their outcomes than the Pfizer model. And just to highlight a few of the scenarios, these extreme points in the CDC model and the Pittsburgh model were when they assumed a relatively high level of vaccine effectiveness of the PPSV vaccine. And the lowest cost effectiveness ratio in the studies from one-way and multi-way analyses was in the Pfizer study, which assumed a relatively high VE against pneumonia, higher pneumonia incidence, and higher case fatality associated with pneumonia. Into the conclusion. So to summarize everything we've talked about today, the vaccine effectiveness appears to be the most important assumption in these models, particularly when considering serotype 3 pneumonia. There were varied assumptions on VE for PCV and PPSV across all the models. Other important assumptions were indirect effects, utility loss per case, and case fatality ratios. The models assume different levels of uncertainty, with Pfizer having the least amount of uncertainty. These are just a summary of the base case values, which ranged from about $200,000 to $765,000 per quality averted. And in the full range, we observed about $46,000 per quality averted up to over $2 million per quality averted. And some references. And I'd just like to thank the teams once again and thank all the folks at CDC who helped me understand the models and prepare the presentation. That's all.
So we're going to hold questions for right now. I'm going to ask Louis Jordar to please offer comment and come up. From Pfizer.
Yes, good morning, everybody. Good morning, do you hear me? Good morning, everybody. I have to say that based on the presentation today, as a preface, I'm going to modulate my comments, and I thank the CDC for including some data. But let me just read this statement. So we are all here today trying to do the best for patients and for public health. PCV13 has already prevented thousands of hospitalizations and deaths in people 65 plus in the United States. I think we all agree that we have a proven safe and effective vaccine against both IPD and community-acquired pneumonia, caused by the 13 pneumococcal serotypes in the vaccine, including serotype 3. For this reason, and although today it's been modulated, Pfizer cannot agree with CDC's assigned value of 0 for PCV13 vaccine efficacy, not effectiveness, efficacy against serotype 3 community-acquired pneumonia as the base case scenario for the cost-effectiveness model. So it has been argued that this is a question of difference of opinions or different interpretation of the data. Pfizer argues that this is not a question of opinion, but a question of facts. And I'd like to review very quickly the data that Dr. Pilishvili has very eloquently reviewed for you on serotype 3. So as you remember, the CAPITA, which is a randomized controlled efficacy trial among 85,000 adults aged 65 plus, served as the pivotal trial to confirm PCV13's indication against vaccine-type community-acquired pneumonia. This should be the primary source of the data for all the estimations. Dr. Pilishvili mentioned, and she was right, that none of these trials were unfortunately powered to measure serotype-specific vaccine efficacy. However, in the modified intent to treat analysis, or MITT, vaccine efficacy against serotype 3 was 60%, with confidence intervals from 5 to 85%. This result was submitted to the FDA in January 2015. Based on this analysis, the base case for serotype 3 just cannot be 0. Now, you didn't see that data in the handout, but I appreciate that Dr. Pilishvili has included that in today's presentation, in the CDC presentation, this MITT data. However, I don't think that's yet recognized in the CDC cost-effectiveness analysis. It is important to note that in the CDC cost-effectiveness analysis, the model used the CAPITA MITT for all the other parameters, with the notable exception of serotype 3. And as we have seen, had the CDC used this serotype 3 analysis as the base case in their model, the results would have been dramatically different. So Dr. Pilishvili has shown in his summary tables a different analysis, a post hoc analysis, different from the MITT that I just mentioned. Just to be clear, that post hoc analysis, which was also derived from CAPITA, included all clinical community-acquired pneumonia, regardless of the radiographic outcome. As shown in her presentation, the vaccine efficacy against serotype 3 was also high at 62%, with confidence intervals from 18 to 83, which supports the basic MITT analysis that I mentioned before. She mentioned also the Louisville data. So as you know, when you pooled, and again, there must be a debate, there could be a debate about the epidemiological robustness or not. But when we pooled the data from serotype 3 for CAPITA, and the only other 2 adult test-negative design studies conducted so far, because as Dr. Pilishvili mentioned, yes, Pfizer has the UAD, which is validated by the FDA to measure serotype specific. When you pull all that data together, we showed a vaccine combined efficacy of 53% with confidence intervals from 6 to 76%. Again, this reaffirms that PCV13 provides a substantial direct protection against serotype 3. The second point that I want to emphasize today, because it was emphasized a lot here, is related to the surveillance population, the population impact data, which I think it's a little bit more debatable. So I agree with Dr. Pilishvili. It is true that serotype 3 has not gone down in the US. However, in countries that have not introduced PCV13, rates of serotype 3 in adults have notably increased. Dr. Bernstein asked, well, I mean, in the European Union, you see a decrease and a little bit and a slight increase, and then in the other countries, you see a sustained increase, and it has been argued that this might be by natural variations. Well, it's almost like there is an epidemiological conspiracy to get the same shape in all the countries that use PCV13 versus the countries that use other vaccines. What we've seen in all countries, and if you look at all surveillance studies, is that yes, it goes down, and I think you've explained it very well about coverage. It goes down and then starts to level, and then perhaps a slightly increase, with the difference with other countries that goes steadily increasing. But what is more important, in countries that have a pediatric PCV13 program but no adult program, and I'd like you to look at the UK and Germany, serotype 3 has dramatically increased in adults. The data suggest a similar trend can be expected in the United States if the adult 65 plus vaccination recommendation is removed. So with all of this as a background, a key question for the entire committee is, will taking this recommendation away lead to unnecessary hospitalizations and deaths from serotype 3 and from the other 12 serotypes in the vaccine? Based on the data showing PCV13 direct efficacy against serotype 3, and given the surveillance trends that we are seeing elsewhere, we judge the answer is yes. Thank you very much.
Thank you, Dr. Charter. Now it's open to questions from the committee. Comments? Dr. Lee.
Sorry. I just wanted to say thank you very much for the scientific input. We really do appreciate it on behalf of the pneumococcal work group and on behalf of ACIP. I just want to also comment that I think PCV13 as a product, we're really, again, thankful for the impact it has had on overall disease burden in the U.S. in both children and adults. With due respect to those comments, I just kind of want to pull us back maybe a step, because I feel like perhaps the bigger issue is, again, thinking about the main issues related to disease burden. I do think that the models are all very sensitive to vaccine effectiveness. And I will say that what maybe didn't come across, and Andrew did a terrific presentation, was that the CDC model was conservative on both serotype 3 vaccine effectiveness and PPSV23 effectiveness. Both were assumed to be 0. I do think that there is uncertainty on both of those estimates, and so having a range of sensitivity analyses is incredibly important. But I think it should be applied perhaps to both estimates would be my sort of personal input on that particular point. So I think applying it only to one or only to the other obviously gives you the two extremes, since it seems like the Pittsburgh model, I think, had some PPSV23 effectiveness and no serotype 3. Conversely, the Pfizer model had serotype 3 effectiveness but no PPSV23. The CDC model happened to be in between. So just from somebody who's been staring at those models for longer than I want.
Thank you. Any other comments from the liaison? Dr. Rockwell, please.
Again, speaking from an outpatient perspective, a couple of things. I think in the reality of putting out a recommendation like all adults 65 and above should receive PCV13, and it needs to be in this order with this much amount of time in between PPSV23, and it should be repeated if you do it wrong and all that. The reality is it takes more than a year to get that enacted, and if not longer. And in fact, maybe it's still not always being done correctly or being given out correctly. So do we know with the data how many of these adults actually did receive the vaccines when they had both vaccines in the correct order, or that it was accounted for correctly, number one? And number two, are we perhaps assessing the data a little prematurely since there hasn't really been enough time to look for longer trends, if in fact these trends from other countries are showing different results?
I think we have presented the vaccine coverage data sort of multiple times at previous meetings, and I'm sure we're glad to put those numbers up again. I do think it's complicated. Like, I don't think the answer is one number, but I mean, you know, do you want to make a comment, Tamara?
Yeah, I think that at the population level, we have looked at it, and as well as part of the special studies that have been presented, looking at the effectiveness and efficacy, and for the CMS population. And I think it's a combination of things as far as like the order in which it was received, which is related to when the recommendations were made. We already had a large cohort of adults that have received polysaccharide vaccine, so there were recommendations for those. But for newer cohorts, we do see the correct order. Now, to what extent that happens, it's hard to assume, because the disease, the surveillance data that we have that tracks the coverage does not really has the power to look at the order in which the doses are received, and that's a limitation.
Dr. Szilagyi.
Yeah, thank you. I know the models are most sensitive to the VE, but I did have a question about the differences across the models and the utilities. Why such pretty large differences, actually, and what were they based on? Are they based on different data sets or different assumptions?
Different source material, and I'll try to go back to it. Well, I won't go back to it. So there were three models. There were three different assumptions on utility loss. I'm just going to go from the top of my head. So the CDC model was kind of using more or less industry or like research standard values that eventually went to a study in 1993 by a gentleman named Fryback. And the way they assessed utilities is they conducted surveys in a community in Massachusetts, and the sample size was, I believe, like a couple thousand. So a long-standing study that's been around for a long time and been used for a long time. The Pittsburgh model took a more like expert opinion approach, but also used values that have been used several times recently. They kind of assumed a fixed level of utility. I think the utility level was 0.4 if you were hospitalized, and they assumed a hospitalization would last about a month, which is kind of a standard assumption around these things. The Pfizer model came from a sub-study of Capita, where they matched individuals who ultimately got pneumonia with other individuals in the cohort in Capita who did not get pneumonia, and they compared the differences in utilities over a year across those two groups. But it's a very new study, and so it's not been used as widely in the literature so far.
No more questions, comments? Okay, we'll move on. So next, I'm sorry, did I miss somebody? Oh. All right, grade and evidence to recommendations, ETR for PCV13 use among adults greater than or equal to 65 years in the context of indirect effects experienced to date, and that will be Dr. Matnock.
Thank you very much. As a reminder about the current adult recommendations for pneumococcal vaccines, in 2012, ACIP recommended PCV13 in series with PPSV 23 for adults 19 years and older with immunocompromising conditions. This recommendation is not being reconsidered at this time. In 2014, ACIP recommended PCV13 in series with PPSV 23 for all PCV13 naive adults 65 years and older, with the following considerations. The committee at that time thought that in the short term, use was warranted because the remaining PCV13 type disease burden, However, it was thought at the time that the long-term utility may be limited due to the anticipated indirect effects from pediatric PCV13 use. Therefore, ACIP proposed that the recommendations for routine PCV13 use amongst adults 65 years and older be reevaluated, which brings us here to today. The policy question, as has been reviewed in previous presentations, is should PCV13 be administered routinely to all immunocompetent adults aged 65 years and older in the context of indirect effects from pediatric PCV use experienced to date. So our population is immunocompetent adults 65 years and older, both with and without chronic medical conditions. The intervention is PCV13 at age 65 years and older, followed by PPSV23. And the comparison is PPSV23 alone, as that was the recommendation before this was enacted in 2014. And our outcomes for this evaluation were invasive disease, or IPD, pneumonia, mortality, and PCV13 safety. To evaluate this question, we have the Evidence to Recommendation Framework, or ETR. Starting with the statement of the problem. First, to put things in context, I want to review what we know about the indirect effects from pediatric PCV use. From the time of first introduction of PCVs in 2000 to 2014, there was a 9-fold reduction in PCV13 type IPD amongst adults 65 years and older. 2/3 of this reduction was in the first decade after PCV7 introduction. At the time of PCV13 was recommended for older adults, and another third from PCV13 use amongst children at the time that PCV13 was recommended for older adults. What was not known in 2014 is what the continued indirect effects would be. Since 2014, there has been a plateau in PCV13 IPD. What we have observed in the US is similar to what other European countries have observed in terms of PCV13 type disease amongst older adults. So that was IPD. For pneumonia, in terms of indirect effects from pediatric PCV use on pneumonia among older adults, most studies have demonstrated a decline in all-cause pneumonia since the introduction of PCV7 in 2000. In the UK, where they're able to measure non-invasive pneumococcal pneumonia using a serotype-specific urine antigen test like that of Pfizer's mentioned today, they observe a decrease of 88% in PCV7 type pneumonia and an additional 30% decline in PCV13 unique serotypes after PCV introduction there as well in 2010. In the US, since pediatric PCV7 introduction, pneumococcal pneumonia hospitalizations have declined. The graph below comes from Fernanda Lessa's June 2018 presentation to ACIP, which showed declines in pneumococcal pneumonia for adults, with the exception of adults 75 years and older, where the credible evidence for the synthetic control model, shown in orange on the second plot, crossed 1. Additionally, for context, presented here is the coverage for pneumococcal vaccines among Medicare beneficiaries aged 65 years and older. In the last 2 bars, it represents 2016-2017 year, where we had approximately 40% of older adults having received PCV13. Included in this gray bar is the number who received both PCV13 and PPSV23, which is about 24%, or as was mentioned, those who have completed the recommended schedule. PCV13 IPD incidence has plateaued at 5 per 100,000 amongst adults 65 years and older. The remaining PCV13 serotypes account for 20% of all IPD, plus an additional 3% when including 6C, a serotype not in the PCV13 vaccine, but for which there is cross-protection. The most common PCV13 serotypes are 3, 19A, 7F, 19F, with 3 accounting for 66% of the remaining PCV13 type IPD burden in 2017. We have discussed before, PCV13 type pneumonia incidence is more difficult to measure. Our US-based serotype-specific incidence comes from Pfizer's Louisville study. The incidence measured in Louisville was 76 per 100,000 in their most recent year of 2015-2016. The incidence presented by Fernanda Lessa today is close to this estimate from Louisville. Using SNP non-invasive pneumococcal pneumonia estimates, we get a much lower estimate of 17 per 100,000, which was presented in October, and is close to some of the other estimates in the literature of pneumococcal pneumonia. So again, this is not just PCV13 serotype specific. The estimate there, though, is applying the ratio seen in IPD to what was observed in SNP. And from the Louisville study, in the most recent year of data, serotype 3 was most common, accounting for 37% of PCV13 types. Comparing the remaining PCV13 type disease burden among older adults to other vaccine-preventable diseases for which there are vaccine recommendations for adults, PCV13 type pneumococcal pneumonia is less than that of zoster or influenza, for which there are universal recommendations for adults, but greater than the meningococcal serogroup B, for which the recommendation is based on clinical decision-making. So now moving to the work group's perspectives on the burden of disease. PCV13 type disease has been dramatically reduced through indirect effects, but some burden still remains among older adults. There is uncertainty about the burden of pneumococcal pneumonia and mortality associated with PCV13 type disease. And since the 2014 recommendations at the population level, we have observed no further reductions in IPD and inconsistent results from pneumonia impact studies. In answering the ETR question, is the PCV13 disease burden still of public health importance? The work group's perspective was probably yes. Now moving on to benefits and harms with the grade. Again, this is our policy question, just as a reminder, as we move into grade. In a little bit more detail, the outcomes of interest that were graded were PCV13 type IPD, PCV13 type non-bacteremic pneumococcal pneumonia, PCV13 type disease mortality, and serious adverse events associated with PCV13. The measures that we used to evaluate this were efficacy and effectiveness, which is individual level effects, and impact at the population level. We conducted a systematic review of studies using the databases listed here, as well as the terms. We reviewed articles from January 1st, 2014 to July 3rd, 2018. Efforts were made to obtain unpublished data or other relevant data, including presentations to the work group from industry and independent researchers. We did make some exclusions to those studies that were first obtained through that systematic review. For observational studies, we excluded ones with low PCV13 coverage in the population studied, or ones where we would expect the indirect effects to be different from those in the US. For safety studies, we excluded studies where PCV13 was co-administered with other vaccines, since severe adverse events in these trials could not be attributed to PCV13 alone. Additionally, we excluded randomized control trials where there was no comparison of either PPSV23 or placebo. In the review process, we screened 2,239 titles and abstracts, and ultimately came down to 20 studies which were graded. The other studies were excluded because they were from other populations, had different outcomes than those in grade, or examining pneumococcal vaccines other than PCV13. So first, to look at PCV13 efficacy, effectiveness, and impact on PCV13 type IPD. This table is the studies that we included. The first two rows are the estimates from capita. as has been mentioned here today, a very large randomized control trial looking at the endpoint of pneumococcal pneumonia. The first estimate is the per protocol, and the second one is all episodes in a modified intention to treat analysis. The two are very close and significant at 76 and 75% for the VE. The second two lines are two case control studies, both using ABC's IPD cases, but with different controls. The point estimates from these studies are slightly lower, but still significant, with confidence intervals overlapping those from Capita. In the last row is what we have seen at the population level in terms of impact on PCV13 type IPD. At the population level, we cannot separate out direct from indirect effects, but have not seen a statistically significant change since using the period just before PCV introduction for older adults to the most recent data we have, 2016, 2017. Before I move on to our second critical outcome, PCV13 type pneumonia, I wanted to go through this schematic, which I hope will help organize the various VE estimates that we have for pneumonia. At the peak of the pyramid, we have PCV13 type pneumonia as our most specific outcome. The studies evaluating this outcome use Pfizer's serotype-specific urine antigen test. There is no similar SSUAD being used for the 75 plus other serotypes of pneumococcus, so we are not able to detect the serotypes causing non-invasive, non-PCV13 type disease. At the base of the pyramid, we have all-cause pneumonia, which is the most sensitive but the least specific outcome. We expect the measures of effect to be smaller due to smaller proportion of vaccine-preventable disease in this outcome, and replacement with non-PCV13 types can obscure the impact on PCV13 type disease when examining all-cause pneumonia. As I present the effectiveness and impact for pneumonia, I will move from the tip of the pyramid to the base. So first, PCV13 type pneumonia, including IPD. The first row is from Capita again. The second line, the McLaughlin study, is the Louisville cohort, where they used a nested case control study to look at PCV13 effectiveness on pneumonia. Both of these estimates are statistically significant, and the observational study from Louisville, the confidence interval is both lower and higher than that seen in Capita. Lastly, for VE estimates, we have one small study from Italy. And in this study, they did not have available an SSUAD. So confirmed cases were from NP, swabs, sputum, BAL, and other sterile site cultures. And they had a non-significant estimate. Lastly, in this table, we have what the impact is at the population level from the Louisville cohort for PCV13 type invasive and non-invasive pneumonia. At the population level, we do see an impact from this study in the 2 years that they used, and Tamara presented that in a slide, but essentially it's the first year of vaccine introduction when coverage was about 11% compared to the second year when the coverage was about 36%. Next are two estimates looking at just PCV13 type non-invasive pneumonia. So these exclude IPD. The first is from Capita and the second from Louisville. In Capita, we do see a statistically significant VE, and from Louisville, the confidence interval at the lower end crosses 0 when excluding IPD. And then moving on to non-invasive pneumococcal pneumonia, so this is not just PCV13 types. at the population level from our surveillance for non-invasive pneumococcal pneumonia, we saw a statistically significant decline between 2013 and 2014 versus 2015-2016. However, when we exclude the declines that we saw that were dramatic between 2013-2014 and just look at 2014 as compared to 2016, there have been no declines in that period. And then at the base of the pyramid, Fernanda Lessa's study presented today, as well as what has been mentioned from the CAPITA study looking at all-cause pneumonia. Both of these estimates are significant, but are lower, again, because this is a less sensitive outcome. So now for our third outcome, mortality. We have very little information for this outcome. The first estimate, again, comes from CAPITA, where they found 7% all-cause mortality in both the PCV and placebo arms over the course of the trial, but no vaccine efficacy against PCV13 type disease, which represented just 2 cases in both of those arms, nor in all-cause mortality. And when we look at IPD mortality from the ABC surveillance system, comparing 2013-2014 to 2016-2017, we do not see a significant change in mortality. So when the burden of disease we observed with the highest VEs from CAPITA, every year we would need, and roughly estimating the number needed to vaccinate. For IPD, every year we would need to give approximately 26,300 older adults PCV13 to prevent 1 case of IPD. For inpatient pneumonia, we would need to give between 3,000 and 14,000 older adults PCV13 to prevent 1 case of inpatient pneumonia. And we need to give approximately 2,600 older adults PCV13 to prevent 1 case of outpatient pneumonia. Since 2014, we have identified 4 published randomized control trials that report SAEs. Presented here is the total number of SAEs. However, it should be noted that the total percentages represent very few SAEs, and most of which were determined not to be related to the vaccine. In addition to the 4 randomized control trials, we have identified 5 observational studies which observed similarly low rates of SAEs. When the results of Haber and Tsang were presented to ACIP in June 2018, the conclusion was that there was no new safety signals or unexpected patterns observed, providing reassurance regarding the continued use of PCV13 amongst older adults. Our conclusions after reviewing the literature remain the same. The following provides a summary of grade. According to ACIP grade guidelines, RCTs are initially given evidence type of 1 and observational studies at evidence type of 3. We downgraded CAPITA, the RCT, for IPD outcome on indirectness because PCV13 was compared to placebo, not PPS23, which is the alternative in our policy question, and for which there is established efficacy against IPD. We downgraded CAPITA as well for the mortality income on imprecision, but it should be mentioned that this was not the primary endpoint and that there were very few deaths overall caused by PCV13 type disease. As I mentioned before, 2 in the both the intervention and control arm. We downgraded the case control studies for IPD outcome based on the risk of bias from potential unmeasured confounding and misclassification of vaccine status, and indirectness for impact studies which looked at population-level effects. Additionally, for pneumonia, among the observational studies, we downgraded based on risk of bias for nonspecific outcome measures. There was inconsistency amongst the results, and among the impact studies, not only we were looking at population effects, but we were looking at over a relatively short period of time, 2 years for the Louisville study and 4 years for SNP. We downgraded PCV13 type disease mortality since our only evidence comes from ABCs, which captures inpatient mortality and in the outpatient setting deaths that occur very proximately to the diagnosis of PCV13 type IPD only. Lastly, we downgraded the randomized control trial for serious adverse events because some of the trials had modified blinding procedures. They had relatively short follow-up, and some used a control group other than PPSV 23. And noted that the observational studies had inadequate or no comparison group, but upgraded these studies for serious adverse events since there has been multiple large observational studies with consistent results. In summary, PCV13 is effective and efficacious in preventing PCV13 type IPD, and efficacious in preventing non-invasive pneumococcal pneumonia of PCV13 type. But the effectiveness against PCV13 type non-invasive pneumococcal pneumonia is inconsistent across studies. Since 2014, at the population level, we have observed no impact on IPD and inconsistent data across studies for impact on pneumonia. The remaining PCV13 type disease burden is predominated by serotype 3, and there's been no impact on mortality demonstrated, as well as no concerning safety signals have been detected. So the work group's perspective on the benefits and harms. PCV13 is effective in preventing disease amongst older adults, but the remaining burden is low and predominated by serotype 3. Based on this summary, the work group thought that the anticipated desirable effects would be small, but that the overall certainty of this evidence was judged to be low because of the limited and inconsistent data for pneumonia. Oh, thanks. You want to see that slide? Sorry about that. Yes, so sorry, to say that again. Based on this summary, the work group thought that the anticipated desirable effects would be small, but that the overall certainty of this evidence was judged to be low because of the limited and inconsistent results for pneumonia and mortality outcomes. For anticipated undesirable effects, no concerning safety signals have been seen since 2014 recommendations were made, with at least 40% coverage amongst adults 65 years and older. For these reasons, the work group's perspective was that the anticipated undesirable effects are minimal, with a high certainty in the level of evidence. In the balance of benefits and harms for PCV13 use amongst older adults, the work group thought that the benefits of continued PCV13 use are relatively small, but outweigh the risks, which are also small. Evaluating just the elements reviewed to this point, the work group favored continuing routine PCV13 use for older adults. Now looking at values and preferences for the target population, or adults 65 years and older. There is a very limited data in this element. In 3 patient-focused studies, participants perceived pneumonia as severe and sometimes fatal. However, there was low perceived personal susceptibility to pneumonia. The work group's perspective was that the potential protection against pneumonia likely outweighed the side effects for PCV13 amongst older adults. And assessing the available information in the ETR framework, how older adults feel about the desirable effects balanced against the undesirable effects cannot be addressed with any certainty. However, the assessment of the work group was that there is possibly important uncertainty about how much adults 65 years and older value the main outcomes. In summary, there's really very little evidence on which to base the recommendation from this domain. Acceptability to stakeholders. There is limited studies assessing acceptability among stakeholders as well, but the work group reviewed 3 studies directly assessing the policy question, which in summary raised the following themes. The current recommendations are confusing for providers. However, providers, when choosing to continue the recommendations or not, choose to continue with the current recommendations. Almost half of the immunization managers surveyed responded that keeping the current recommendations may be programmatically of advantage if new higher valency conjugate vaccines were available soon. And that while there is insurance coverage for the current recommendations, reimbursement for vaccines is still a programmatic issue. The work group has deliberated on the domain of acceptability for continued use of PCV13 amongst older adults, taking into account the following considerations. So the considerations for continuing PCV13 are that the overall impact on PCV13 type disease from vaccinating older adults is minimal in the context of indirect effects from pediatric PCV13 use. Considerations for continuing PCV13 included that PCV13 can provide individual level protection against the remaining burden of disease, and that frequent changes and recommendations may negatively impact the perceived importance of future adult vaccine recommendations and may present implementation challenges. With these different considerations, the work group opinions did not coalesce around a single judgment on this domain. So, resource use. As was summarized in Andrew Leidner in his presentation today, there is important uncertainty for some of the inputs, primarily what the VE against pneumonia is for both PCV13 and PPSV23. However, the majority of base cases and sensitivity analysis provided an estimate higher than what we had in 2013. Comparing the results we have today with the evidence that went into the decision in 2014, we have the first column with the 2013 model results, which was the estimated public health impact at the time of the decision. However, in 2014, we anticipated that there may be additional indirect effects from pediatric PCV13 use, so the model was also projected forward to 2019. 2019 was when we thought that the indirect effects would have reached their peak. Those model results are represented in the second column. In the third and fourth columns, we have the current estimates, first assuming no effectiveness against serotype 3 disease, and then assuming 26% for serotype 3 IPD and 45% for serotype 3 pneumonia. We have updated the assumptions with new information that we've gained in the past 4 years, but roughly the cost in 2013 was $65,000 per QALY adjusted life year. It was projected to be $287 per QALY in 2019. And now that we are actually in 2019, we estimate the cost to be approximately $220,000 per QALY. If we assume effectiveness against serotype 3, and $561 per QALY, assuming PCV13 is not effective against serotype 3. So the work group's perspective on the resources used. Implicit in the economic models are the same level of uncertainty that exist in the evidence for the burden of disease and benefits from PCV13 use. However, with the updated information now that we have compared to 2014, the costs per QALY are estimated to be higher now than they were in 2013-2014 when the recommendation was made. The work group thought that PCV use among older adults was probably not a reasonable and efficient use of resources. And now for feasibility. Current recommendations are complex, but have been integrated in many healthcare and public health systems. Universal age-based recommendations are easier to implement than risk-based recommendations. Medicare currently covers the recommended pneumococcal vaccine series for older adults. If a change in the current recommendations is made, CMS will review the new recommendation and supporting evidence. It was brought up by workgroup members as well that some states have regulations that allow public health nurses and pharmacists to provide PCV13, which are tied to ACIP recommendations. And that effective communication strategies will be needed if policy changes are considered. In answering the final question, the work group thought probably yes. PCV in series with PPSV23 is the current intervention, and so continuing it would mean continuing with the status quo, versus removing PCV13 and returning to the previous recommendations of PPSV23 alone for adults 65 years and older. And now bringing everything together. The options for the type of recommendation considered were the following. We do not recommend the intervention, which would mean PCV13 would no longer be recommended in series with PSV23. Option B, we recommend the intervention for individuals based on clinical decision-making. And C, we recommend the intervention, which would mean continuing the current use of PCV13 in series with PPSV23. As of our most recent discussions, the work group members were either in favor of discontinuing PCV13 or recommending PCV13 for individuals based on clinical decision-making, with a small minority supporting continued current recommendations. However, there were many key issues raised when considering the different recommendations options. Here is a summary of these key issues. Reasons raised in favoring of continuing routine PCV13 use included PCV13 is effective in preventing PCV-type pneumococcal disease. And while PCV13 type disease has been reduced through indirect effects from pediatric PCV use, they have not been completely eliminated. Universal age-based recommendations are easier to adhere to than risk-based ones, and frequent changes in recommendations may negatively impact the importance of future vaccine recommendations and may present implementation challenges. Reasons raised in favor of discontinuing routine PCV13 use included the overall impact on PCV13 type disease from vaccinating older adults is minimal in the context of indirect effects from pediatric PCV use. The remaining burden of PCV13 type disease limits the potential benefit from direct effects, and there's been a lack of clear population level impact since 2014. This would be the most judicious use of public health resources, and discontinuing PCV13 for older adults would be a simplification of the recommendations. So the next steps. I think our next steps are to hear what you all have to say today, most importantly, but in planning forward, providing an update summary of the evidence to recommendations framework in June 2019. There are a few outstanding results that we know about. Mostly these are studies that are wrapping up final analysis, and so we will provide any updates. Those include the mathematical model, which Tamara presented a slide on and mentioned having discussed before, the 2 case control studies using ABC's IPD cases, and trends in serotype from the Native American adult pneumonia etiology study, which was first presented in June of last year. Additionally, we know about a survey of primary care providers looking at acceptability and feasibility, which we should have summarized by June of 2019. And in June, we anticipate a vote based on your feedback. So I just wanted to acknowledge not only the work group members, from ACIP, many of the other work group leads who've been helpful with the grade and ETR, but also the many people who reviewed the evidence. And so with that, I guess we can open.
Thank you for that presentation on ETR. Committee, any questions, comments? Go ahead, Doctor.
So one of the questions or issues I didn't hear addressed in the summary, but I may have been alluded to earlier on, in terms of resource utilization, is, what would be the resource utilization to that would result from removing the recommendation, and then potentially within a year or two, as the PCV 15 or 20 become available, reinitiating a recommendation for this population, using the same rationale that was used to put PCV 13 in place for this population. And so, I think that is, an important consideration, and potentially, feedback on or any additional information for our group to help us in the consideration would be helpful.
Yeah, that would be over here. We agree this is a really complicated topic, and so we appreciate all of you thinking through what additional information might be helpful. That complex question is probably something we need to pose to CMS, and we'll do that and try to get some information before June. So other bits of data or pieces of data that you all think would be helpful to try to sort through your thoughts about this issue would be really helpful if you could try to raise them today.
Dr. Foster.
I'd like to weigh in on a little bit of this. The acceptability portion where the work group could not make a decision, I think pharmacists could weigh in a little bit on that one. As far as the states that allow pharmacists to do this vaccine is probably 100% of the states. So pharmacy is very much involved in this process. I can tell you that we put a lot of resources into getting the recommendation understood within pharmacies throughout the country. The fact that, and by the way, I do remember some discussions with the meningococcal ACYW135 being kept in the schedule twice because of program issues. So I think that that's a feasible thing that we've done. But I think removing it now and then trying to implement something in within 1 year or 2 years, whatever happens to be, if we do have some new vaccines come on, would be really discouraging or very difficult to do within the pharmacy basis. It's taken us about this long to do it. The other thing is I think most of us didn't really realize back in 2014 when we said 2018, the only data we would have would be up to 2016 or 2017 data. We thought we'd have more data, available at that time. So from the standpoint of pharmacy, I would be supportive of continuing it until we see what next vaccine's coming out.
Thank you. Dr. Alt.
Do we have all-cause mortality data from this huge Medicare and Medicaid data set that was discussed, just presented? It sounds easy to get that, but it may not be.
We have some of that information, and we can provide it within the summary next time. We definitely have looked at the case fatality ratio, but mortality, I don't know, would have to ask Fernanda about the mortality over time, but whatever we can get from that study, we can include in the summary. Yeah.
Eche.
Thank you so much. This was something that is quite complicated to follow through. So I really appreciated the slide that you had in the last one, which is a summary of the key issues for the decision. I think this, to me, reminds me of the decision we had to make at several meetings ago about LIV. The reason being that there is fact before us, but there were also programmatic issues that we have to consider in making those decisions. If you look at the summary of the key issues that you have here, majority of the issues here are programmatic. We know for sure from data that there has not been any population-based impact. That's fact. But we're saying that if we do remove it, that we are going to have some programmatic issues, and which is the messaging about if we introduce new vaccine in the next 2 years, about what the pharmacist's investment has been, and we're going to lose those things. So most of those things are programmatic issues, and they are important. But also there is this fact that there is no population-based impact. So it comes back to how people view what ACIP role is. And that is this fact. Are we to be viewed as a committee that we say the facts and vote on the facts, and some people will know that when we make a decision one way or the other, that is based on a fact. And that fact includes the programmatic issues that has to be considered. But when the fact is that a vaccine has not made any population-based impact over the past several years, not that we're anticipating any more, unless we're saying that we need more data to see whether there's an impact. But if we have concluded that it's no population-based impact, then the question is our decision solely to be made on programmatic issues, and whether, or rather, do we maintain the committee integrity by saying if the facts are before us, then we can make decisions based on the facts. It was a very difficult decision for any of us, or for me, to make on LIV, but the fact was what the fact was. And so this is a little bit of a guidance from how we are supposed to view this. I know we're not voting at this meeting, but I think it's important to see if there are any more things that would change what we have today, maybe the data from CMS, but if the data, and I think that data would be in terms of fact, are we certain that there is no population-based impact over these years? Do we anticipate there's going to be any if we let 2 more years pass by to get more data? And if now we have to make decision, is the programmatic issues enough to continue this vaccine?
I just want to comment that, yes. I mean, Melinda always reminds me whenever these issues come up that are really complicated, that's why we have ACIP, and that I completely agree that this is an incredibly complex issue that is at the boundaries of data and judgment. But I have looked over the past couple years, and many of the issues that we pose to you are in this same space where it's not so obvious what to do. And those of you who are on ACIP now, you may look back at the people who were on it 10 years ago who had easier decisions than you do. So let us apologize for saying yes. I mean, that's the whole point. When there are these issues that pass by when there's data, we have to ask you to use judgment. And Grace, you probably can comment on how difficult it's been within the working group.
I'll just say that, the reason that acceptability box was so broad is because the entire work group as a whole I've seen sway from one side to the other, and I've seen even individuals on the work group sway from one side to the other. So it's because the problem is we agree with all of those statements. There's nothing wrong with any of those arguments, and so this is the judgment call that I think we are going to be forced to make, which is, it doesn't feel good though.
Dr. Stevens.
So, where to begin? I think this is, as was pointed out, obviously a very complicated issue, but we introduced a platform in 2014, and I don't think we've seen the impact of that platform, quite frankly. 20-something% coverage in the order, and I think the order of which these vaccines are administered is important. We're really doing a prime boost strategy with a conjugate followed by a polysaccharide. To go back to a polysaccharide alone strategy seems to me to be a mistake, at least in my looking at the data. I just don't think we've seen enough data with the proper use of the conjugate followed by the polysaccharide to make a difference. I would also a bit argue with the term immunocompetent. These are not immunocompetent individuals in the sense of many of them have many of us who are approaching that, have conditions that are significant conditions with medications and so forth. We saw the data on the greater than 85 in terms of pneumonia. I mean, this is not immunocompetent as we would define immunocompetent. So I would argue and urge us to think a bit more about immunocompetent. So those are a few points. I think that more data in terms of this platform is important. I do agree very much about the coming introduction of potentially even better conjugate vaccines for this population. So thank you.
Dr. Talbot.
This is more of a procedural question, but after Dr. Hammett's presentation yesterday, it really kind of rung true. If there is that population of Native Americans that are still at high risk for pneumococcal disease because we have not eliminated disease in kids, would that require a whole nother working group and vote to give an indication just for them?
So procedurally, and please chime in, Dr. Weiser, but from an ACIP perspective, we would have to consider that group as a high-risk group then separately and have a vote. Now, I don't know if IHS can make different types of decisions outside about who they purchase vaccine for, but if this recommendation turned into, if we took away the recommendation entirely, then I think we would have to have another work group. If we kept in that individual clinical decision-making, there could be potentially some broad-based decisions by IHS. Do you want to add anything to that?
A couple of things. One is that IHS is not the only group that immunizes American Indians and Alaska Natives. So, for example, the recommendations around influenza and treating influenza with antivirals has made a big impact on helping others who aren't part of our system to do the right thing. So I think it would be really interesting. I was looking at one of the last slides. It mentions the Native American Adult Pneumonia Etiology Study, which I'm not familiar with. So I'd like to hear more about that maybe at the next time.
Yeah, I can just to briefly mention that, and happy to share those, but that was presented in June of 2018 initially, and Laura Hammett, who presented the information, not only provided what was known to that point in the amongst Navajo and Apaches for the etiology of pneumonia, but also looked at the impact of PCVs overall in both Alaska Natives and the American Indians living in the Southwest. And there have been similar impacts. The rates of disease are still higher, of course. And the etiology study, unfortunately, is not pre-2014, so we can't look at impact from it. She is going to try to estimate VE, but there is, as you well know, very high coverage rates in that population. And so probably looking at VE will be difficult. Sorry to interrupt with that.
Thank you. Dr. Walter.
Yes, I'm still struggling with, from the first presentation, looking at the direct effects. And this is not taking cost into considerations. Looking at the direct effects of the vaccine, PCV13, when you take out serogroup 3, that you had a slide in there showing that when you took that out, and I think this was from the ABC, that if you look at the direct effects then, that there is efficacy. Is that correct?
So maybe I should clarify. So the study utilizes surveillance data and the coverage data in order to tease apart direct and indirect effects. So we are using essentially what we observe and trying to attribute how much of it was due to direct effects versus indirect effects. When we take out serotype 3, the trend looks very different, and therefore there is more to be attributed to direct effects given the coverage. But when you include serotype 3, the trend looks as flat, and therefore there's nothing to attribute to direct effects. So this is not like a direct effectiveness study where you're comparing vaccinated to unvaccinated. We're still utilizing surveillance data and how it looks over time in order to attribute these effects.
But in our summary presentation, we didn't take that out, basically. We accounted for all. I mean, is that still the right way to look at it?
So I think we should separate direct effectiveness, where effectiveness was moderate to low demonstrated when you compare vaccinated to unvaccinated, and when we look at the impact over time.
I guess my point was still in the last presentation we didn't take out serogroup 3, and should we do that?
No, we can look at that and sort of reevaluate for next time if that.
Yeah, I guess one point along
yes, go ahead. We can look at that. Let's keep going.
Yeah, so I just want to say whose hands we have up, and so who's speaking next. So we have, next is Dr. Goldman, Fry, Grog, Dr. Eze, and Moore. Just so if you're on that list, you don't need to keep your hand up. We'll go through. Dr. Goldman.
Thank you. It's certainly a very complex issue, and we've been struggling with it. Certainly, as a private solo practitioner, I always struggle with population health versus the individual patient in front of me. And I always have been taught, trained, and still believe my most important responsibility at that moment is the patient in front of me at that time until the next patient comes in and their most important patient. So while population health is, of course, of great importance for this committee, I do think we also need to remember that even if we're reducing pneumonia risk in one patient, as practicing physicians, that is of great concern. And there needs to be that leeway for that individual clinical decision-making. So while cost is important, health coverage is important, we do also have to stress the fact that the vaccine does have some benefits. It's not zero, it's not completely ineffective, and that even if we're reducing the risk of pneumonia-related death for that one patient, it's 100% for that one patient. So keep that in mind when we make these decisions regarding the individual versus the population.
Dr. Fry.
Thank you. This may not be a fair or an appropriate question for this discussion, but it would help me think about the overall picture due to the complexity. But can we find out where the PV, I believe it's 10 and 15, are in their development and the timeline for potential applications or approval?
Could I ask anyone from pharmacy?
Let's not, okay, so we can put that, let's make a list of things that you all want us to talk about at the next meeting, because I think that, we asked the pharmacist, we know what the companies are going to say, we can certainly include it, but as we all know, and as FDA will tell us, those timelines are always incomplete. So let's make a list of things that you all want to hear at the next meeting, and we'll make sure that that gets on there.
Great. Dr. Grug.
Yeah, Stan Grug from American Osteopathic Association. I'm going to hit it from practicality. We finally got our physicians trained to give the Prevnar at 65 and the Pneumovax at 66. And there's questions about what the effectiveness is. And new vaccines coming out, my suggestion would be keep it like it is until we can figure out the new vaccines and have to re-educate our physicians and others practicing.
Dr. Etche.
So this is more of a procedural guidance. So do we have to make a vote in June? Is it possible to defy that vote so that we can have a couple of things happen? One is to see if there's going to be an increase in uptake from, if we think that 20% uptake is not enough uptake for us to judge whether there's a population-based impact. At the same time, we are thinking that in that period of time, that infrastructure that we have built for adult immunization can wait while maybe we have to reevaluate another vaccine. But do we have to vote on these three choices that is there? Or could we say we need more information, and then what implication does it have? Do we keep the working group for another year? So what's the implication of not voting in June on this?
So the quick answer is no, you do not have to vote, but not voting on this issue is essentially maintaining the current recommendation. So it is still a decision to be doing that. And in terms of implications in future data, I think, I do think that this committee has so many issues coming down the pipeline in the next couple of years that I do think that closing out this issue for a period of time would be helpful and not continuously reevaluating it. But we can continue if that's we can continue that conversation.
The problem is that we are really not closing it out. So if we take a decision now and then in a year or so, we are going to come back to the same decision. So if we say continue this, and then in a year we come back and say, well, let's not continue anymore. We seem like we're not sure what we're doing. Instead of saying we'll defy this vote, and then because we need more information, and then when we take a vote, procedurally, I don't know.
I think that we can discuss the work group's terms of references and how they prioritize kind of after we get more feedback on this particular decision. But I think the answer is we do not have to vote on this decision. That is up to ACIP.
Dr. Moore.
Thank you. I very much appreciated all the conversation. As Grace mentioned, I'm one who's of three minds about this, and depending on the moment. But a question that would help me is, what might be the unintended consequences to particularly vulnerable populations when we try to look at the overall population effect, and we say we don't see much of one? Are there inadvertent unintended consequences to certain more vulnerable groups within that population who are getting more benefit or who have more potential for benefit, that if we made a change in the recommendation, if we dropped the routine recommendation, they might be affected more so than others? One thing I think of is that risk-based recommendations are so difficult to implement and spotty, and we know that that age-based recommendations are much easier to implement, and we've had that for a while here. So I'm just concerned about whether there are data of any particular subpopulations or vulnerable communities, like the American Indian, Alaska Native adults, that might have special circumstances we haven't discussed.
Thank you, Dr. Coyle.
Thank you, and I realize I probably should have made a comment about this yesterday as well, but one of the decisions I think that you all are considering is related to based on the patient and provider considerations and what they decide to do. From a systems perspective, it's really helpful for you all to consider, what do you want the provider to do? What information do you want them alert to? And how does that react a little bit differently? So the example is if you have a provider that's looking at the recommendation, do you want that displayed ahead of time? Do you want it recommended for all patients, or is it only going to be for a certain percent of that? Or is it that the patient needs to know about the recommendation before they walk in the door? So from a systems perspective, it'd be really helpful to consider that as you're evaluating your decisions.
Thank you. Dr. Baker, sorry, forgive me.
I'll keep it short. I think everybody should have heard, and if not, go back and read the minutes. I agree with Dr. Stevens' statement.
Thank you. Dr. Bernstein.
I wondered whether it would be helpful, and this may not be an appropriate request, but I would be interested to know about the annual number needed to vaccinate and also the cost per QALYs for other vaccine-preventable diseases recommendations in comparison to this.
So that is actually something that we typically don't present. We think that these are each individual decisions. There's obviously a wide variation. We can provide some background information for you guys. I do, if I could quickly go back to Dr. Baker's comment, could you please comment, Dr. Baker, about whether or not that's an IDSA perspective that's been discussed, or if that's just your personal opinion?
Well, that was my personal opinion. We are interacting officially with the IDSA, especially if there will be a vote, because I think this is a very important thing. However, a couple of comments. One, and I'm not being critical, it's just the way it is, invasive pneumococcal disease is a very uncommon event due to vaccine containing serotypes, and there's a huge indirect effect. Thank you, pediatric and adult pediatric vaccine providers, for that. I think it's very difficult, I don't have a solution, to measure direct effects. For example, how many people 65 and older, some of us may be there, who got PCV13 and who didn't get pneumococcal pneumonia, because if you got pneumococcal invasive disease, you'd be reported and hospitalized. How many people had mild pneumonia, went to the doctor, community acquired, got medication? This is difficult for you to be precise. I think if you had really good data saying there's X in the population who now remained healthy, yeah, they had a healthcare encounter, but they didn't get hospitalized. It's very difficult. But I think the programmatic, and I will answer your question about what the IDSA says when it comes to June. Either I or Jeff Dushin will comment. We'll get some feedback, but I suspect for the people who are vaccinating in the IDSA, which includes pediatricians as well as adult providers, that some of the comments about systems dismantling and then remantling future advanced conjugate vaccines are all going to be very important, because when you're an immunizer, you're a physician and your duty is to deal with an individual patient. It's difficult.
Thank you, Dr. Baker.
Can I also just comment that it would be really helpful for the liaisons in this particular situation, which is so complicated, for you to take this back to your organizations and be prepared in June, especially for those of you who are major stakeholders in this issue, to really give us, I mean, we always value your personal opinions, but if your organizations want to take a position on this, I think it would be really helpful for the voting members to hear some of that feedback.
Thank you. Dr. Adler.
I just want to make a comment about, one of the issues with influenza vaccine was after the Medicare demonstration project and the increased uptake of influenza vaccine in the elderly population, there had been, and maybe still is, great concern about being able to demonstrate population-based effects. We eventually moved to the test negative design to show vaccine effectiveness in various age groups. And in fact, that may be something that would be similar here, although I'm not a modeler and would have to get input from, people more expert in this area to figure out whether my analogy is accurate or flawed in some way. But the lack of population-based effects is maybe a little troublesome, but I don't think it should be fatal. And I think some of the data showing evidence of continued direct effects should be given some import.
Dr. Szilagyi.
Yeah, like everybody, I'm really struggling with this. In terms of the three possible decisions, do not continue individual decision-making, continue. I think it might be helpful for us, for the work group, to sort of think through, if there was an individual decision-making, what guidance would we be able to provide? Because as a primary care physician who gives vaccines, although to kids, I'm having a hard time coming up with what kind of logical guidance would help for primary care internists or family physicians in this. And it goes along with David's comment about a 65-year-old is not the same as a 75-year-old. I have a hard time judging immunocompetence. There's this enormous range, and I personally would have a very difficult time trying to figure out what is the risk of this patient, and it would be easier to measure potentially their individual values, but a risk would be very difficult. So that might be some helpful information.
Any other comments? Then I'd like to close this session by going back a little bit. So I think one of the things that the chairperson offers is institutional memory, and having sat on this committee now for 5 years, some of you may remember the vote that we had on the pneumococcal B vaccine and the discussion that Dr. Frieden had with us. And essentially, that discussion, if I may paraphrase it, is that we should not be paralyzed by lack of data, that we act on the data that we have, and that we project our decisions based on those facts that are present. We make reasonable assumptions, and if those assumptions need to be modified at a later date, so be it. But we are tasked with coming up with a plan or a reasonable process forward, and I think that's important for the committee to bear in mind.